Good morning, everyone. Happy Tuesday. Welcome to the Multnomah County Board of Commissioners' 7th budget work session. Audience members, I want to start by asking you to please silence your electronic devices. For those presenting today, please turn your mic on when you begin speaking so the green light is showing, and off when you've completed your remarks so the red light is showing. For all presenters, please state your name for the record before speaking or responding to questions. And I just wanted to note that we have a little bit of technical difficulties here in the boardroom. We aren't able to see the presentations online, so apologize for folks in the audience. You are able to access the presentations and download the slides from our board clerk website. So that is a way to access it for the board meeting materials. But Tasia, is that affecting anyone's view?
Tasha's working on getting things set up right now.
It should be able to be seen on the YouTube.
Okay, so so folks watching online should not have any issues today with seeing the presentations. All right, and with that, I'll go ahead and invite our health department to come up to start off our several board work sessions that we're going to have around the health department. This morning, we're starting with an overview in the director's office. And for that, we have Health Department Director Rachel Banks and her leadership team. Good morning.
Good morning, Chair Vega Peterson, Commissioners. Good morning, Commissioner Moyer, Singleton, Brim Edwards, and Commissioner. Okay, we're having more than one technical difficulty this morning. Here we go. It's like that. My name is Rachel Banks. For the record, I use she, her, and hers, and I'm your Health Department Director, and I'm here with the fabulous team that I'll let introduce themselves.
Good morning, Board. My name is Valdez Bravo. I use he, him, his pronouns, and I serve as the Deputy Director of Operations at the Multnomah County Health Department.
And good morning, Chair Vega Peterson and Commissioners. My name is Angela Henderson. I'm the Health Department Deputy Director. Can't talk this morning either, so another technical difficulty. Deputy Director of Strategy and Policy, as well as Racial Justice and Equity.
Good morning, Rosalie Lee with the Health Department CVAC, and I'm the chair.
Welcome, everyone.
So we're going to do our best, but give us reminders if to be clear on which slides that we're on as we're walking through our paper copies. So this is just the introduction slide. We are really excited to be here. We know that there's a lot of information you'll get from the health department. We have a phenomenal number of slides to share with you this morning, and we'll try to contain the excitement. Some of what we're going to be doing is talking about the phenomenal work that we get to represent on behalf of all of the employees of the health department. We'll be doing our best to monitor time and all that. But I just wanted to start off with kind of giving you all a couple of overview comments. One is, and that you'll hear in this presentation and hopefully in a variety of others, one is that we really approach this budget differently than has been done in a number of years, starting with the outcomes and strategies that we want to achieve, and then moving towards the financials and putting together the budget. The other is that we focused on the unique governmental health roles. There are a lot of phenomenal people that do health work and provide health care in our community, but we are the only entity that is responsible for the health of every single person at every single point of their life at any time they're in Multnomah County. And with that come a variety of statutory roles that we'll talk about. And the other is that really the power of the health department and in order to achieve health outcomes, we need to be working at multiple levels and stringing together comprehensive strategies. So we will be talking about what that looks like from the prevention to the intervention continuum throughout the life course and working at individual and societal and community levels. So the next slide is just our agenda slide. So briefly, we're here today, as the chair said, talking about the health department overview and some of our cross-cutting departmental supports. Next, today you'll hear from our corrections health team, and then following you'll have behavioral health, public health and the health officer, and then our integrated clinical services, our health centers. So before I hand it over to the phenomenal Rosalie, I just want to take a moment to thank every single person in the health department. If you're listening or in the crowd, the work that we do every day is because of those people, the heart, the soul, the mission that they put in, that they carry with them every single day. It's been a hard budget year, and everyone has been right in there. So I just want to thank everyone. And then introduce our phenomenal CBAC chair, Rosalie Lee. Rosalie is a dedicated and has shown herself time and time again, especially with us in the CBAC, to be a dedicated community health advocate and academic research professional. She has over 2 decades of experience leading strategic healthcare and research operations. She's made a lasting impact by serving some of Oregon's most vulnerable youth and families and communities. Thank you. And through the delivery of innovative, trauma-informed, and culturally responsive services. She has been the chair of our CBAC for a number of years, and she's led the development in the Health CBAC of equity-driven recommendations to guide our public health investments through some of the most challenging times that we've seen in health and healthcare. She's elevated community priorities, strengthened collaborations with our department leadership, and advanced transparency and accountability in the budget process. So with that, over to you.
Thank you so much. I appreciate you, Rachel. Again, good morning, commissioners. I want to thank you for the opportunity to speak today and start off by welcoming and acknowledging the exceptional efforts of our newest CBAC members, Courtney Wood, Dima Abu Ali, Gwyneth Pensoni, and Hannah Studer. The committee remains grounded in our shared values summarized by the following principles. We are transformative leaders. We offer expert knowledge. We uphold racial justice. We operate with dignity and respect. We believe in intercultural intelligence and hold ethics at the core. Bless you. Yeah. These principles shaped every conversation that we had, every recommendation we made, and every question that we asked. Beginning September, between September and March, we met with department leaders, listened closely, and did the work of aligning priorities with the reality of the proposed reductions. Director Banks oriented the committee to the health department values, division services, and the FY26 budget. We reviewed 15 program offers focusing on strategic restoration. Our CBAC asked which programs align with the department's values and the impact that our community hopes for. And we also asked where must we hold the line to maintain critical infrastructure. So several of the programs that we prioritize, such as the STI clinic and the school-based mental health services, were partially restored in the chair's proposed budget, and we thank you for that. But want to remind you that these are just not health interventions, that they're public safety and social justice strategies. They reduce harm, prevent crisis, and interrupt punitive systems that disproportionately push vulnerable students out of school into incarceration, or what we know as the school to prison pipeline. These programs offer lifelines. They prevent harm, they build trust in the community, and they serve those who need us the most. So now let's talk about the bigger picture. What is strategic restoration? Why is strategic restoration critical? Healthcare costs are rising, revenue is shrinking, and the needs continue to grow. If we don't restore infrastructure, if we don't support the people that make this work possible, the risk isn't just operational, but we risk human capital. Cuts to these areas destabilize our foundation, they delay services, they hinder recruitment, and jeopardize our ability to respond to emerging threats. That's why we have identified programs like the infrastructure bundle, which we believe is critical in the restoration priorities. We believe that these aren't just administrative lines. They're systems that essentially hold everything together. They ensure that community-based organizations get paid on time. They help us to not only train, but retain staff. And they make sure that when the next crisis arrives, that we're ready. Today, I'm asking you to support 3 things: to protect and invest in our workforce, invest in prevention, because if we wait until people are in crisis, the cost in lives and dollars is always greater. And then finally, we ask that you pursue equitable cost savings. In conclusion, and on behalf of the CBAC and the communities we serve, I want to thank you. I also want to take a moment to acknowledge the Chair's office, the Office of Community Involvement, and just say that we've seen the steps that you have been taking to improve transparency and engagement. We see that and we appreciate it. Again, we continue to urge you to protect the infrastructure, protect the workforce, and to protect the community members that rely on us. Thank you so much.
So we're going to be switching in and out, I should have said in this presentation. Thank you, Rosalie, doing a bit of musical chairs there. So slide 11 is where we'll be next. But before there, I just wanted to thank the CBAC, thank Rosalie, again, thank all of the employees, the teams who put this budget together, and also take a moment to apologize to all of the health department employees who have been hurt in the process of budget reduction scenarios. It's heartbreaking to me to think that any employee, particularly those who are represented in the reduction scenarios that we needed to put together, would think that their work is not valued or not seen and appreciated. So why do we do the work? We are here ultimately, simply put, to get outcomes. Those are outcomes like reduced chronic diseases, increasing life expectancy, providing health and behavioral health care, getting folks into treatment. We do that in three major ways. We protect people from health harms, we promote services and healthcare, and we prevent the spread of disease. So protecting people from health harms looks like ensuring safe food and drinking water. It looks like community-wide risk communications on the health harms, public campaigns, promoting health and healthcare. We have an expert dental, primary care, behavioral health care workforce, and we deliver those services to thousands, tens of thousands of people. We compile health data to convene partners. We work with culturally specific partners to come up with strategies to end health inequities. And we prevent disease spread by providing outbreak response, disease intervention services for a variety of communicable diseases. And we do things like, just in our spare time, take on big tobacco to stop the leading causes of death in our community and protect youth from initiating to tobacco. We're the local public health authority, you all, the local mental health authority, community mental health programs, and the largest federally qualified safety net, or federally qualified health centers. We really are the safety net to the safety net in a lot of areas, as well as providing those services. We are there at times of people's great personal vulnerability, whether that's in their first 1,000 days of life, through incarceration, through sickness, or treatment that's needed for a variety of different conditions, and ultimately through recovery. We serve our community without judgment and with particular favor, and we're the only entity in the county that is responsible, again, for every single person at every single point in their lives. So slide 12, we do this through being based in our mission, vision, and values. And as the entity that needs to be ensuring health at every point of folks' life, we focus on policy development and working with you all. That is one of the best ways that we can get to the health of all people, as well as rectify, reconcile, and redress health inequities that are or systemic racism injustices that contribute to health inequities, is at that policy and institutional level. We are focused on understanding health needs, data and outcomes, and ultimately delivering high quality and consumer-driven healthcare. So on the next slide, I will talk about the leading causes of preventable death. We focus here, and you'll hear me say this, because this is where we can have the greatest impact and because this is where the most egregious health inequities are. We simply cannot achieve our mission of ending health inequities without addressing the leading causes of preventable death and things like chronic disease, injury, so on and so forth. So this slide, there's multiple blues. It's a little bit busy. I'll walk you through it. Again, slide 13. So we have a team of epidemiologists that pull this information together, track data and intelligence across multiple domains. We pair this with community wisdom that either tells us what it is that we should be monitoring and or tells us what we should do about the data, the health trends that we're seeing. This data is coming through death certificate data on the leading causes of death from 2019 to 2023. People ask, why just 2023? Because it's the most recent year, or the most recent data available, because the time it takes to process through some of these results. So in this slide, these leading causes of death are coded with the color gradient. We have both the leading causes across the whole county, which I'll talk about, and then we have it broken down by race and ethnicity, which you can see. So the highest mortality rate across the county is from cancer, which you can see throughout the panels. That's in the dark blue. And then each of the columns represent a different racial and ethnic group, with the first column is the whole county, and then the other racial and ethnic groups. The top 5 leading causes of death across the county are cancer, heart disease, unintentional injury, stroke, and COVID. Again, many of these deaths are preventable, and that's where we're focused and what this budget represents. When we look at the data by race and ethnicity, you can see that the order of the leading causes of death shifts for different communities. Many are still in there. And this data helps us draft and craft culturally specific strategies and responsive strategies to the needs of particular communities. As you can see here, the leading cause of death, for example, among American Indian and Alaskan Native people in our county was unintentional injury, while the leading cause of death for Black and African Americans in the county was heart disease, as an example. On the next slide, I'll talk about, it's 14, causes of unintentional injury, and this is where we've seen increases the past number of years as this rising as in the category of leading causes of death. This is also one of the places that yanks down our life expectancy as we see things like overdoses contributing to this. So, and as we look at particular communities, like we just saw the American Indian, Alaskan Native population, this is the highest leading cause of death for them, for example. So in this graph, you'll see that in the gray, which is the overall unintentional injuries, 833 of them were due to unintentional drug overdose. And then the 236 in the blue on the bottom are due to traffic fatalities. Drug overdose is blue. Gray is overall. Unintentional drug overdose is blue. And then the orange is traffic fatalities. The others are a mix of things, including poisonings and some other things. On the next slide, which is 15, I'll talk about, yeah.
I'm wondering if it's possible to get, just so we have some sort of comparator, would it be relatively easy to get something similar for like Washington, Clackamas County, just to see how we compare in the metro area?
Yeah, I think, let's see, we'll definitely reach out to them and see what they have available, and then what we can glean from what we have.
Yeah, it would just be interesting comparing across the region.
Just one other piece that came up for me is we know people experiencing homelessness have a life expectancy of about 56 years, which is way below any other population. Is domicile unknown the only place that we're tracking those? Is that where we'll find the leading cause of death for that population?
It's one of the places. I don't want to say it's the only place,
Okay.
so let me get back to you on that too, if there are other places
Yeah.
to look at that,
Thank
for
you.
sure. And I'm glad you brought that up. I mean, that's one of the things as we talk so much about culturally or community-specific strategies, is understanding things like that and then unpacking that, like whereby we also look at, for example, tobacco use in populations that are experiencing homelessness and a variety of, or experiencing mental illness or behavioral health issues. And, there's multiple overlapping things, what I should have said underneath these leading causes of death, which we work on as well, those social determinants.
Is it possible just to get some absolute numbers, like by year, just?
How many?
I'm trying to get the sense of the scope.
Yep. Absolutely. So on slide 15, talk about the years of potential life lost. So for me, this is where we look at our data, and all of these, which I'll explain to you, result in years of life that we didn't have to lose, deaths that that didn't have to happen in that time frame, that are people that are our loved ones. I think about each year of this is somebody's birthday. It's another year sitting around the, campfire or whatever with your loved ones. It's another time welcoming young ones into another year of their birthday. It's all of our loved ones, brothers, sisters, friends, moms, and all of those. So I just want to really, as we talk about this data anytime, particularly this, center and the realness of what we're looking at. So this is estimated years of potential life lost by assessing how early a death was compared to age 65, for example. This data, again, has the same parameters as before. It's the same years, 2019 to 23. The 2024 data will be analyzed and forthcoming. The light blue on here shows years of potential life lost due to unintentional injury, mostly overdose, as I mentioned, and the dark blue is cancer. The moderate blue color is heart disease. So unintentional injury has caused large losses in potential life, as mentioned, notably among particular communities, our American Indian, Alaskan Native population, Black and African American populations, Native Hawaiian or Pacific Islander communities are dying younger and unnecessarily across all causes compared to other communities when we look at this. And again, we measure and focus this because preventing preventable deaths is where we can have the most impact, and it's ultimately where the most egregious health inequities are. But these numbers are staggering when you're talking about thousands and thousands and thousands of years of life for communities, hundreds of years, tens of years of brilliance and wisdom and joy and magnificence that our communities are bringing and that we're losing out on. So that is the why we do the work that we do. We'll talk more about the how we do the work that we do. It's a long-term endeavor for us, and we're going to keep at it. Next slide.
Can I ask a clarifying question? Why do we use it, years of potential life to age 65? Why the year age 65?
It's a calculation of what an average may be in terms of life and a comparator to, I've actually seen it done differently, but our team used 65 here. I can get you some more specifics on maybe how they shifted. Yeah, just, it's
Do we
obviously
stop trying to
arbitrary.
prevent death after 65?
If you're after 65, we're done. No.
No, I'm kidding. Let me make that clear.
So am I. So am I. It's a benchmark, a baseline for us to use. Clearly, our goal is to get many, many years above 65. I appreciate you asking that question because I support that. Awesome. So we are now on slide 16, our responsibility. Again, we have multiple statutory requirements and that we overlap. And I'll just say really the power of working in the health department is our ability to work across all of these domains to get big outcomes that no one entity or no one strategy could achieve. So that's what you see here in our departmental approach. You'll hear over the number of days how we work strategically across these to achieve collective impact. And, just to note, we play roles that nobody else can or should at times do. And that is where in these very difficult budget scenarios, we have backed into what are those statutory requirements, what are those unique roles, and what are our functions both to serve individuals but work at the population level. Slide 17 has a number of things going on. I'm sorry for folks in the audience who can't see it. I think it's a really cool slide, but it talks about us working at multiple levels to create change and really maximizing our potential as a health department working across multiple domains. So an example of this is our work that we'll talk about and you'll hear about in every single presentation is our work in our overdose prevention and response strategy. Why? The data that we just showed you. And there's multiple ways that we do this. So this graphic represents what's called a socioecological model. It basically says what we know, that working across all these levels at the same time on a particular issue is the way you get the biggest impacts and changes in health outcomes. We support individuals work with their communities and their interpersonal networks, ultimately work with institutions, whether that's schools or faith houses or, employers, whatnot, work in communities, and ultimately the policy level. So using the example of overdose and prevention, there's a variety of different things. We distribute naloxone and training to prevent overdose to those individuals. We use and distribute resources for safe storage of medications to prevent misuse and to prevent accidental ingestion in the family or, interpersonal settings. We, in our corrections health, which you'll hear more about, have medications for people with opioid use disorder, as we know coming out of incarceration is a high-risk time. We promote recovery in youth overdose campaigns in the community level. And we work with you all at the policy level. One example is providing health expertise and implementation of deflection policy, as well as years before of prescribing policies and other things that we work with folks on. So next slide is 18. I'm going to breeze through some of this. Again, we really work as one department, maximizing those capabilities. This is another example of how we do that in our overdose prevention and response. But we have a number of pillars. We prevention, harm reduction, treatment, and ultimately recovery. So we want to prevent initiation to use, folks starting to use in the first place. We want, if people are using, we want to minimize the harms that are associated with that use. Ultimately, we want to prevent death from overdose so that we can have time to be working with people to get into treatment and ultimately live phenomenal lives in recovery and with their communities. In the next slide, slide 19, this is an example of us working across systems with enhanced surveillance, public education, naloxone distribution, et cetera. I'm just going to give you some specifics on our Expect Fentanyl, some of our community-wide education campaigns. This one is Expect Fentanyl campaign that you see on this picture. It's intended to raise awareness, particularly in the younger population, 13 to 20, about how to recognize and respond to an overdose, to understand the dangers of fentanyl and the health harms associated with it, and teach them how to obtain and use naloxone. This campaign was delivered to the devices of young people across our county. It received more than 2.9 million impressions and nearly 18,000 clicks, which is impressive, and it's also an extremely cost-effective way to deliver health education and information. The campaign extended from the youth portion to the entire community through advertising on billboards and transit. Please take a look around your neighborhoods and communities. You'll see that we are rerunning this right now, and give a shout out when you see that there. We also ran educational campaigns, including 2 recovery-oriented campaigns, Recovery is Possible and Recovery Takes Community, that is promoting recovery, destigmatizing campaigns, and using local people in recovery, really intended to increase knowledge about recovery and some of the treatment services. So in those campaigns, for example, that featured the joys, big and small, that others have found in recovery. It directed people to our partner network, Recovery Network of Oregon's website. And in the time that we ran this, we saw the campaign traffic on their website increase by 20%, exceeding our nearly 20%, 19% exceeding our initial projections. That was their website featured information in both English and Spanish. So slide 20 continues to show our collective response in overdose prevention, featuring the work that was stood up for our deflection program. And of course, we're going to keep working as for sobering in our crisis stabilization center, getting into the permanent center. We are proud that we worked with our partner organizations, with the county. Big shout out to everyone who helped do this. We ultimately stood up the new facility in 62 days. And we will continue to do that work. But I will tell you, it was a feat. It's good to be on the side of it talking about
There's the reason they got the Cheers Award at the employee recognition.
Totally. Yeah. So the next slide, 21, is, so all of these things that I've talked about, and these multiple different domains that we're working on, what are the outcomes that we're seeing because of that? This is an example of data, and this is overdose deaths, and you can see reducing overdose deaths. So as we know, it's clear why we're focusing on this. There's obviously, I'll say at the outset, more work to do. We don't want to accept any overdose deaths or any deaths that we can prevent, but you can definitely see this trend going off. We do not intend, and this budget keeps our foot on the gas in terms of overdose prevention and response. But what you see here is two data trends. So the black line is the provisional number of confirmed overdose deaths from death certificates. That's over the first 3 quarters of 2024. And you can see that fatal opioid overdoses have declined over this time, as they have done nationally. This is our local information. So the blue bars on the slide show us the quarterly number of naloxone doses provided by the county. And so between the first and fourth quarters, we clearly increased our naloxone distribution across the county, and we're seeing decreased outcomes. I will say this is a multifactorial in terms of why these numbers go down. It's not just naloxone distribution. It's not just the education campaigns. There's a variety of other things that contribute to this, including drug supply and so on and so forth. That caveat said, this is exactly the trends that we want to be seeing. This is exactly the trends that we talked about with you all, that we were aiming for when we were here before and doing the work of the combined fentanyl response task force and so on and so forth. We also, just for you all's perusing enjoyability, have our public Tableau dashboard that is available, and we'll be releasing a fentanyl report as well. So more to come on that.
Is it possible on the slide to get, just a follow-up, the national trends? Because I think I saw something last month that nationally the deaths have gone down 27%. So it'd be interesting to see whether we're tracking that or beating it or lagging behind. So
Yeah.
would love to see that, just like an added line on the graph. Or
Sounds good. What I will tell you in short is that the national trends are going down, as is ours. We're not beating them. We're a little slower than the national trends, and we, again, are going to keep our foot on the gas and keep these numbers. We want to keep them going down.
I have a question. I am assuming, but I should not make assumptions. The overwhelming majority of opioid deaths are fentanyl related,
There's
or opioid and fentanyl.
There's the increase is driven by fentanyl related, but the opioid deaths also are multi-substance. So we see meth, opiates, alcohol. So there's a lot of things in here, but I will say the increases that we've seen over time largely been driven by fentanyl.
Okay, thanks.
All right, slide 22, overview of the numbers. So orienting you to our budget, and here is our FY26 operating budget, $523.7 million, which is a decrease from 4% from fiscal year 2025. Our FTE decreased by 48.33, which is about a 3% decrease. We experienced general fund decreases in most of our departments, save ICS, who saw a healthy increase to deliver the healthcare services needed, and they'll be here to talk about that. So just want to acknowledge, obviously, it's a hard budget for all county divisions, the health department no less. And in the health department, our budget issues are exacerbated by the loss of federal funding, whether that's COVID era funding, the threats to continued federal and local, state revenue, which we'll talk more about. But the decreases are general fund, but they're not solely general fund decreases. So in slide 23, I'll talk briefly about our budget approach here, and then look forward to passing this off here really soon to hear from some of these other presenters and the phenomenal information that they have. But for our budget process, we really use this rubric, and as I mentioned, started with strategy, centering our population level outcomes that we wanted to get, and ultimately ending health inequities. So the outcomes, you have guessed it, preventing leadable causes of preventable deaths, preventing causes of preventable death, ending health inequities, achieving metrics that are tied with the accountability metrics, whether that's our work that we do with health systems, public health modernization metrics. There's a variety of different metrics which you'll see in our program offers, and we're happy to talk about, and using data, community wisdom, and evidence-based practice along with innovation. So slide 24 digs down more into the budget decision-making, which of course started with the chair's budget priorities, our work in reducing preventable deaths, particularly those from overdose, suicide, injury and violence, chronic disease, health equity and racial justice, both by providing services in a variety of places, in a variety of ways that are accessible to people, as well as transforming systems that are carrying the inequities that are pressing down on our communities. We want to be excelling in business and improving our business rigor, maintaining an expert, and as Rosalie talked about, workforce, and maximizing our unique governmental health roles. So I will just note throughout this process, we looked at our vacancies right away, eliminating vacancies that we could that did not track to the criticality of our work or meet our budget rubric criteria. So the next number of slides, 25 and 26, I'll just lump them, really talk about our values that underpin this and the things that we were doing in this budget, protecting our core services as directed, and ensuring that we could carry out our duties as the local public health, mental health, community authorities, as well as community mental health program, supporting the physical and behavioral health needs of our community, focusing interventions where we can have the most impact and end health inequities, mitigate the health impacts of emerging threats, including climate change, and protecting the health and honoring the basic community dignity and humanity of the people that we're honored and blessed to serve. The next slide in 27 is how we incorporated equity in budgeting, and you'll hear much more about this, but ultimately we start with analyzing the data and the trends so we understand what our outcomes are for the communities in which we serve. We also clearly look at equity as it relates to our workforce and the people that we serve. We collaborated with boards, including our CBAC, our public advisory committees, our governing boards. We assess the potential impacts of reductions, both in our budget rubric, and then you'll hear as the divisions as they went down and did their budget reduction scenarios, and ultimately focused on funding programs that fulfill the statutory roles and where we can have the most impact. We asked ourselves at every juncture, and I will just be honest, the answer was not always yes. Have we centered our decision-making in whatever session this was, whatever work session or activity that we've done? Have we centered it on inclusively leading with race? And whereby it was not enough or not this time, then we would go back and redo that work. The test, we had many hours together in section. So it does that not only just on Zoom, but like in person, where you're like, I'm touching things. Thank you. I appreciate that. I do want to note here as we walk through the rest of this presentation and the division presentations that because for so many years we have tried to focus on equity, health equity, ending health inequities, that there is no way we could make these level of reductions without impacting equity. So I'm not going to sit here and say that equity was not impacted in the budget reduction scenarios that we put forward. It absolutely was. We were trying to mitigate that where possible and keep that at the forefront. This budget, though, is exciting, and it represents our three-pronged strategy, which Angela will talk more about in achieving equity. That is, we work from the health department outwards with boards and commissions and culturally specific coalitions to influence, again, those policy levels, the institutional levels, to make sure that the policies and systems are more equitable there and that we're hearing from communities and it's impacting our work. So health department out is one level. We work across the department in setting outcomes, targets, aims, and goals for things like workforce recruitment and retention, having equitable policies and practices that are implemented and well-tracked that benefit our entire workforce. That's our WESP work, for example. And then the third level is we work vertically within our programs and making sure that we have vertical systems and structures so that when we hear providers on the front lines and the communities that we work with on the front lines and they are sharing with us what they need or innovative best practices, that those are infusing the work that we do up and down throughout the organization. So I'm really excited to be here and to be introducing Angela Henderson, because I was here with you all, some of you all, last year talking about the vision for equity and really expanding into a three-pronged inside-outside equity strategy designed to get health outcomes, support our workforce, deliver culturally specific trauma-informed and appropriate care and all of that. And a key part of that strategy was hiring a deputy director who was going to build out our Office of Health Equity, including hiring an equity manager and some of the positions that's been vacant. Our steps that has happened, Angela's here. I'm going to pass it over to her to talk with you more about where we're at.
All righty. Thank you, Director Banks. And again, good morning, everyone. Angela Henderson, Deputy Director, as Rachel already described, of Strategy, Policy, Racial Justice, and Equity. Before I begin, though, I would like to just say that I'm truly honored to be a member of the team and to work alongside these wonderful colleagues here, many of whom are in the audience, but I would say the majority of which perhaps you have not had yet the opportunity to meet. And we have a department of, I'll just say, approximately 2,000 team members. And it's those behind the scenes heroes that really, truly make the work that, oh, wow.
We now have
No, I'd be so
slides.
excited about that.
Let there be smiles.
Right? Thank you, Valdez.
Maybe?
Yes, slide number 29. I'll wait till we get there, actually. Thank you. And as I was saying, it's those behind the scenes heroes that actually make the work that we do in the health department possible in service to community. And so I want to not only lift that work up and acknowledge them publicly, but also to say in this forum, thank you to all of them. And it's not lost on me the amount of dedication and expertise that each of them possess. So again, thank you. The health department, as Rachel has described and what you'll also hear from other presenters as this week ensues, is quite large and unique. And because of that, we have a broad scope of statutory responsibilities and multiple lines of service delivery as well. The Office of Health Equity, as you see centered in the graphic above, will be the point of focus for the department to strategically guide us and the work that we do under a one department approach and enable the health department to systemically innovate in initiatives, partnerships, and services, as well as optimize our capacities as local public and mental health authorities. Deliver on a comprehensive, as Rachel described, action-oriented, I must say, external and internal plan, and align our investments accordingly with both our mission, vision, and values so that we effectively deliver population-level health outcomes. The public health and the social determinants of health frameworks themselves require such investment and alignment in order to achieve the vision of population-level equitable health outcomes. And this new structure that you see depicted here is both a model that provides leadership, focus, and visibility, but also it is responsive to the challenges of today with line of sight for and vision for tomorrow. Slide 30, please. So this is a wonderful graphic, but it's also quite a bit of information in there. And I'll summarize it by saying, as Director Banks already touched on several times, the health department has to work at multiple levels to actually address the complex health inequities that our communities as well as other communities face. And then this visual, we again want to emphasize the importance of focusing efforts on coordinated upstream approaches excuse me, to population health solutions that address root causes of those health inequities so that we are actually tackling, again, the causal factors and not simply treating the results of them, such as illness and even mortality, quite frankly, premature mortality. And so particularly thinking about social, structural, and institutional inequities is what we're focusing those solutions towards, because we know that when we can focus our energy on these drivers, again, we tackle those causal factors that I just described, not just the symptoms, and in so doing, get a multiplier effect that then galvanizes us across sectors in collaboration, community-driven and culturally responsive solutions, because we also partner with communities, various communities that are represented in the work that we do and who live amongst us. And also policy alignment, again, with both our mission, vision, and values, but policy alignment to effect and help shape those outcomes. And it's in our work that this is both our why as well as our what. Slide 31, please. So what do we do in pursuit of health equity? You can't see along, well, actually, there's not much along the bottom there, but I'll read that last column when we get to that. So what you see depicted here is that health equity is both a process and an outcome. So it's how we do the work, but it's also what we desire to see at the very end. So what are we yielding as a result of all of this work and effort that we're putting into it? And this framework for reducing health inequities that we just went through and that I just shared requires addressing and changing the conditions, again, that create these inequities. And so we proactively target and address upstream root causes so that we're not just simply reactive and, again, treating those downstream symptoms. And our strategies and programming, which you see in columns 1 and 2 depicted above, are driven by data, or informed by data is what I actually like to say, as well as informed by community, and they help to ensure that our interventions are tailored to the specific inequities and priorities of the communities that we serve, all of which are supported by internal and external community expertise and investments that create pathways to improved health outcomes like those that we've alluded to earlier in this presentation, as well as access to our services. And they're supported by health improvement strategies and community-tailored approaches and solutions, like the Healthy Birth initiatives that you see in the middle there, as well as promoting access to hope and a workforce that leverages diverse lived experiences from many of the community members who are also engaged in the work and have lived experiences that can help inform the strategies and as well as relate to the various communities that we serve together, which form the foundational infrastructure for long-term change. And just for everyone's edification, the third bullet in the blue square there reads as workforce development programs. So you can't see it because, okay, thank you. Right on. Appreciate that. And with that, I'll turn it over to Valdez, my colleague here, and slide number 32.
Great, and I just want to do a time check. We have about 78 slides to get through, and we're at 32. So I just want to
Pick up the pace.
Yeah, pick up the pace.
All right. Shifting up to fourth gear. Okay. Hey, everybody, Valdez Bravo again, he, him, his pronouns, Deputy Director of Operations. And, as we move into this next section, really just kind of depict a picture of like these investments and what this work that both Rachel and Angela have talked about looks like in action. This slide really seeing our budget in action, just to pick a few of these, our behavioral health division is we running the Pathway Center, which stands up the new stabilization and deflection facility. Our Friends in Corrections Health recently expanded their use of medications for opiate use disorder, giving those transitioning from jails a better chance at a healthy transition back in the community. And, our Women, Infants, and Children's Center, our WIC Center, is going to be moving to a facility in the Rockwood neighborhood in 2026 to, truly meet the needs of the largest, most diverse, fastest growing WIC clinic in the state, serving 50% of all WIC's yearly caseload. These are just a few examples of the many investments and the different types of work that are happening all around the county, all along the health department. All right, next slide. So, we thought we'd depict just a little bit of a sampling of the numbers of the people we serve because, from womb to tomb, cradle to grave, as Rachel said, at every point of the life course for every single person in the county, we serve everyone across our county. And these numbers just kind of are a testament to that, whether it's the 55,000 served through the community health centers or 18,700 people served annually in corrections health. the numbers kind of speak for themselves in terms of some very specific impacts. And again, that's just a sampling of some very specific services and program offers that the health department offers. All right, next slide. Now, those are aggregate, sometimes it's, okay, who are these people? Who are these 18,700 people? Well, at the community health center, 60% identify as people of color. We're offering services and culturally specific offerings and programs in a variety of languages to meet the patient's needs. 84% of our folks have Medicaid, which of course is on everyone's mind, as 1 in 3 Oregonians are on Medicaid, but definitely here in Multnomah County, we have a high number of our folks using those services. 3% have no insurance at all. Sometimes we think, we've got 100% people covered, but we are the safety net of the safety net, as Rachel said, and so it's very important to have these services. All right, next slide.
A quick question.
Yes.
Do we ask about housing status at our community health centers?
Believe so, but we'll probably defer that to their presentation.
Okay.
Just to make sure that,
Just to put it out there, I'll be interested in the number of folks who are unhoused that are being served.
I can see that being a screening question. Okay. All right. Thanks, Commissioner Singleton. With the WIC, and happy birthday, WIC, 50 years and looking good. 50,380 visits, 19,000 unique clients, 6 service sites, and $8.7 million in healthy foods distributed to participants. So, yeah, as we all know, the WIC provides a variety of services to parents, and not simply just the food vouchers, which is a very important aspect. Another place we wanted to zoom in on, next slide, is the Behavioral Health Resource Center. And what a great testament to the investments that in the health department and resulting in the community. The BHRC started on May 5th, 2022, and it just came out, it just immediately grew into its own, being a huge, impactful place of hope and connection and referrals and healing for so many people in our communities. You can see the day center, serves over 6,800 unique clients, 80,000 visits. We have people, they're coming back and and re-engaging, which is the name of the game when it comes to outreach and referrals. 10,195 referrals, 63 showers a day. I mean, you can see the numbers on the slide. We also have our mobile health outreach van, which is in Old Town, which is that great strategic location right by the health department, right by Blanche House. People are able to, get some breakfast, come over, get their ticket, have their time that they're going to come over to the BHRC and benefit from these essential services. And to personalize this just a little bit further, if you could go to the next slide, I want to tell you the story of Sean. And if anyone's downloading this presentation from the website, this is linked in the slide, or you can just go to search BHRC Multnomah Sean, and this story will come up. But this is Sean, and Sean found himself homeless for the first time in his life after his mother passed away. He couch surfed and did whatever he could just to survive that hard time. And he was actually living outside when he found the BHRC. But he felt safe there, and he couldn't believe the compassionate treatment and the opportunities available to him through the program. But with the help of staff and peer support, he was able to get his life back little by little. First, he got his Social Security benefits, and then a bank account. And then after participating in services at the Resource Center, he qualified for transitional housing in the building, because there is that building, there are beds in the building, first and foremost. And then working with a caseworker, he's now working to find his own apartment. And Sean's words of encouragements for others that may be listening, viewing this, watching, who are facing the same challenges. Sean says, no matter how bad it looks, no matter how bad you think it is, you can turn it around. And that's what the BHRC helps people do daily. Okay, next slide.
On slide 36, I think just like we talked about with Homeless Services Department, I will want to understand what these referrals, like what the actual outcome of referrals are. And then similarly, I think in the van and outreach encounters, it's like what is the service that's actually being provided?
A little bit of a picture.
Helpful to know.
Yeah.
Thank you.
Is that just coffee? Is that a ticket to the BHRC? Is it something more? Yeah, we can definitely make sure. And then slide 38, again, smallest county by geography in the state, but definitely the most populous and most diverse. And we are providing services to all of our residents spanning the county and beyond, because we take that tri-county approach. Communicable diseases don't really recognize borders. And so we're doing a variety of things, whether it's vector control or student health centers, community health events all across, just really a variety of offerings and services we're doing for community, in community, by community, looking to community to lead, and we simply amplify the work. All right, next slide. How we do the work is the next little piece of this presentation, and I'll go to the next slide. And, so how are we investing in eliminating health inequities? Well, we're using legislatively mandated public and mental health authorities. It has been talked about before with Rachel as the LMHA, LPHA, and operating the CMHP, Community Mental Health Program, to create a comprehensive internal external strategy, and then having that strategy and building an action-oriented strategy. What do they say? A strategy, a vision without a plan is only a dream. Like, we are taking that strategy and turning, we have the plans to operationalize it. And then in leveraging our newly created Deputy Director for Policy Strategy Racial Justice Equity position to focus those efforts and developing out the Office of Health Equity to include the current CPCB, or the Community Partnerships and Compatibility Team, the Equity Team, others, we were able to collaborate with department advisory boards to really inform and drive and amplify that work. Oh, yes.
Yeah, can I ask make a request for follow-up information, because I think it would be quite helpful?
Sure.
Can we get a breakdown of what our local mental health authority actually means versus, which could be hours of presentation, and any other kind of statutory requirement / power? Then, on a separate thing, and I've asked potentially for a presentation of the split between what the Oregon Health Authority directly pays for and is in charge of, what CCOs pay for and are in charge of, and what we do in relationship to those and on our own as the public health authority or local mental health authority. Thank you. That'll be fun. I think AOC has some of it.
Well, so, and I just want to say, I appreciate the question so much, because we had a really big conversation with the previous board and with Commissioner Brim Edwards on when we were working on the CLP Plus plan that Commissioner Myron was working very closely with the health department on. And so I think a couple of the presentations that might be good materials as we're working to get some of this additional information that answers some of the questions that you're posing in there, because this is a perennial question, I think, for the board members, is to truly understand what does our role look like, and what does that authority mean, and how does that relate to the other partners in our health system? So we can make sure those presentations get shared.
Okay, awesome. All right, slide 41, please. So we're in the classrooms, we're in the streets, we're in the community, we're in the clinics, but it takes infrastructure to make all this direct service possible. There's really, we have our, direct service divisions, but behind them and supporting those frontline staff, or operations, which was an investment in 22, recognizing that we didn't have enough support, undergirding the frontliners that were doing the COVID operations. So a lot of that was falling on top of individual, contributors and supervisors. We, of course, have our finance and business management team led by Derek Moten. We'll meet in a little bit here. Strategy, policy, justice, racial equity, and then Rachel, the conductor, bringing us all together so that we're rowing in one direction and on the same sheet of music, or picking an analogy for synchronicity. But it really takes that kind of centralized control with the department that is so big across, 2,000 plus people, or almost 2,000 people. Okay, so next slide. So basically, what does this require? This requires, skilled administration, revenue collections, we got to have a sustainable operation here. Compliance oversight, many ORSs, many compliance, many county rules to, go into informing our work, how we do this. And quality management, are we doing the thing? Are we hitting the benchmarks? Are we hitting the targets? Are we meeting our outcomes? So whether it's KPIs, process metrics, or outcome metrics, evaluating that and looking at it with dashboards and reports. So our frontline workers, without infrastructure and without those investments, that's going to kind of fall on them. They're going to have to stop doing what they're doing to focus, stop the service delivery to kind of do these aspects. And so we really want them to work at the top of their licensure. If you're a mental health consultant, we want you to do mental health consultant work. If you're a nurse, we want you to do nursing work. We want you to be able to do that and not have to and do this other things that less clinical or less specialized people might be able to assist with, or maybe that's their specialty, assisting. So the size, scope, and specificity of the health department really does kind of require us to embed these infrastructure supports at the department level, because whether it's the specialized recruiting of physicians, nurses, mental health professionals, and other clinicians, or the unique aspects of medical billing and health contracts, some of the most complex kind of contracts there are, the health department's operations really benefit from having these supports close to the work. And there's a variety of things that investments that might look like. But at the end of the day, you know, really service providers need to work at the top of their licensure, spending their time with clients, and infrastructure makes that possible to do all that work and to support it and to maximize and optimize the talents and passions and know-how of our direct service providers. And with that, I'm going to turn it back over to Rachel to talk about HRAP.
Sounds good. So the next number of slides talk about our HRAP. I'm going to breeze through this. There's other materials that our colleagues who are responsible for this do a great job in putting out. Next slide, please. So here's, I'll pick out a couple of examples, and then the behavioral health, next slide, please. Division will be up, and they'll talk more about their work in a number of these areas. So one example for goal 3 is the work that we do to support the operation of Bridgeview that you'll see in this budget, which provides housing services for 47 adults in Portland. For example, they provide 3 meals per day, on-site 24/7, nursing support, and medication management. And so we know that without, at times, without these supports, individuals risk returning to houselessness or having difficulty qualifying for other levels of care. We also know that these supports help prevent hospitalization and ensuring that we're doing our part to support folks having housing off the streets. Next slide. There's examples all embedded in this, which include our outreach and peer services, which we can talk more about, the BHRC, which Valdez shared with you all. If we go to the next slide, some examples of the work that we do in these school areas are assertive community treatment, intensive case management programs that keep individuals with psychiatric and substance use intervention in long-term housing. If we go to the next slide, some examples here are the work that we do to support vouchers, for example, with the ACT Assertive Community Treatment Program for the folks that we serve in those programs. Next slide.
Can we get outcomes data for this work?
And, well, yep, for ACT. Yep. So this is a list of investments in supportive housing. Again, the behavioral health group will be back in front of you all digging down, and we'll be talking about bed services, dollar amounts, outcomes, and more information that I know you all are interested in. The list continues on the next slide for your reference. And then with that, I will hand it over to Trista.
Thank you, Rachel. Good morning, Chair Vega Peterson and Commissioners. For the record, my name is Trista Zugel. I use she, her pronouns, and I am the Health Department Budget Director. Trying to breeze through slide number 50. Next slide, please. This just explains the difference between our operating budget of about $523.7 million, which is the focus of which covers all of the work that has been described in the presentation so far. We have contingency, that internal cash transfer that you see there listed for $13.4 million. That's actually a cash transfer from the Health Department Director's Office to the Department of County Assets for the development of the Permanent Sobering and Crisis Stabilization Center. Roughly $70 million in reserves, which is predominantly set aside by integrated clinical services. And I will have, oh yes, the next slide. I really like this slide because it gives you a great idea of the size and scope of the different divisions within the health department. You can see the ICS is our largest division. ICS is quite unique. There's no county general fund in ICS, or they use no county general fund, and it sits in a distinct account known as an enterprise fund. The next largest divisions are behavioral health and public health, followed by corrections health. And then, of course, none of this diminishes the critical impact of the smaller divisions, like the director's office, financial and business management, the health officer, and operations. Next slide.
Good morning, Board. My name is Derek Moden. I use he, him, his pronouns, and I'm currently the Interim Director for Finance and Business Management. And on this slide, we see the operating funds for our FY26 budget as compared to our FY25 budget by source. This slide really just highlights that there are a couple of decreases in our county general fund, our other funds, as well as our supportive housing services funds. And I would like to call the significant decrease in Fed state funds, and it's primarily due to the deflection funding that we received in FY25 that was budgeted in the operating funds that for FY26 budget, it should be in the DCA budget. Finally, I would like to note the increases in our preschool for all, as well as in our fellow ICS, which is the Federally Qualified Health Center. Next slide, please. This slide right here shows our FTE trends for throughout the years, and I really want to highlight that our staff here at the Health Department is one of our most vital and valuable resources, and as such, it's a top priority for the department to ensure that we are adequately staffed to meet the needs of our community, and as such, our FTE has decreased by 48.33 FTE from last year, which is a decline of roughly 3%. Again, as noted by Director Banks, the decrease is roughly about 3%, and is primarily focused in county general funded positions. Also would like to call out that there is a trend of increases in both our FQHC, which is ICS, as well as preschool for all, as well as the demand in our behavioral health systems, which we have a slight increase. Next slide.
Can I ask a clarifying question? Of the, I'm sorry, now I'm forgetting the exact number of FTE reductions. What is the breakdown between management and frontline staff?
We don't have that currently, but I will make sure we get that to you.
That'd be great. Thank you.
Next slide is our operating budget by category, and just, personnel expenditures continue to be the primary expenses that flows through the health department, followed by our contractual services and internal services.
Okay. Moving on to indirect revenue, I am going to go over this briefly because I know that we're running out of time. But I did want to take a few moments in this presentation to point out the distinction between reductions to our general fund expenses that relate to the reduction in the county general fund forecast and the allocation that we receive from the county. We also have internal general fund revenues, and one of the most significant ones is indirect revenue. As you can see on this slide, our rate declined from 12.8% in 25 to 11.5% in for 26, projected for 26, and this led to a year-over-year decrease in indirect revenue. Which doesn't really account for all of the reductions that we had to take, because in addition you have increased costs. So that relatively smaller pot of revenue is paying for more expensive personnel and services. So next slide. So just to make that a little bit more concrete, I'm providing you with this pie chart. It shows you the breakdown of our general fund revenues. This revenue comes from a mix of program revenues, such as restaurant inspection and fee and tobacco licensure revenues, which we discussed in an earlier presentation. Additionally, we received some funds from the county opioid settlement that sit in our general fund allocation. But what we call department indirect accounts for roughly 13% or 20 million of our available general fund in the budget that you have in front of you. So significant changes in rate have significant impacts in the department's budget. I do want to note that the indirect rate is calculated by our trusted internal partners in the Department of County Management and are based on well-established federal principles. It's just that mathematically, between last year and fiscal year 25, that rate declined. And so we manage that internally. So next slide. So what this meant is that we needed to take reductions internally to get to current service level before we even began to entertain the 12% constraint request. And so this gives you, when you look at our reductions tables, you're going to see county general fund, you're going to see general fund reductions and internal general fund reductions. And so you'll be able to understand that those internal reductions are due to the changes in our internal revenues. And with that, I will pass it back to Rachel.
All right, thank you, Trista. So this next slide talks about key new investments, which you all have heard about, including our ambulance service plan, some augmented and specialized IT support for health projects and initiatives, the behavioral health comprehensive local plan, which I believe, if I have the dates seared in my memory, Commissioner Moyer, it's like December 3rd, December 17th that we talked about that, but we'll get you those where it answers some of the questions that you asked about our CLP when we were here last time. Next slide, please. These are for your reference, some significant county general fund reductions for public health. They will be back here with you all talking about that. The next slide similarly has significant proposed county general fund reductions for behavioral health. They will be in front of you all talking about this tomorrow. If we go to the next slide, this is
Rachel, can I just jump in real quick?
Sure.
For public health, program offer 40096.
Okay.
I'll want to understand the impacts of those reductions
Okay.
on programming.
Thank you.
Thanks.
Can I also get clarity on what the 5 FTE, which I assume is, oh yeah, and it's an addition for the Sobering Crisis Center will be doing, that's 40104B?
Absolutely.
And since you're taking notes.
Yeah, taking notes.
Definitely interested in hearing about the impacts to program offer 40054.
Okay.
Family
Yep,
partnerships.
thank you.
So
And 40061, harm reduction specifically what.
Okay.
this is like a more general question, but relating to the sort of the finance piece. So Multnomah County has had a decline in population. And I'm curious whether, what the trends have been in like the major service departments. Are we seeing like a corresponding decline or increases? And I don't need the answer now, but I'm just curious about, so we have fewer people living in Multnomah County. What impact has that had on services?
I have a couple more.
Yeah.
Yeah, 40048 as well. And then 40044A. Follow up after.
Great. Cool thing about my job is I get to say, and they'll be back talking to you all about this. I'll take great notes, and then they'll answer some of this in their presentations, and we'll follow up where needed.
Yeah, the division should have more detail.
Totally. Great. So I went over most of the things in this slide. I'll just move on to some legislative things that we're paying attention to. Clearly, the legislative session is in session, but here's some updates as of May 7th. So we're looking at the House Bill 5025, which is the OHA budget bill for a number of areas, the $25 million ask for public health modernization, some of the capabilities that we talked about. Of course, your proposal for the Medicaid pilot for people with SPMIs in there as well. In HB 2024, that's the behavioral health workforce bill, which would appropriate funds in 45 million to OHA for workforce and behavioral health workers, which would be great. HB 2059 for new residential behavioral health capacity, which would fund programs that increase statewide capacity for withdrawal management, as well as residential treatment facilities. There is HB 2467, increasing civil commitment eligibility, HB 2056, which is important to us, would close the community mental health program funding gap to provide services for individuals that are unable to aid and assist in their own defense and are involved in civil commitment processes. That would provide $32.4 million a year pass. And then HB 2934A would create a pilot that would have hospitals to screen for hepatitis C, HIV, and syphilis when providing a blood test, and then we would follow up as we do. The next slide talks about federal funding impacts, and Derek touched on this in his presentation. And what this is showing you is the health department divisions that have significant federal funding, which include our community health centers and ICS, public health and behavioral health. This shows that the federal funds make up 5%, 20%, and 23% respectively of their total FY26 budget.
Can I do a follow-up question? For FQHC, are you not counting CCO dollars as federal dollars?
Let me have them answer that.
Okay, because I don't know how it could only be 5%.
So just for clarification, that is their federal grant. So their entire function, so this is intended to show you the impact of federal grants. The entire FQHC function is a federal Medicaid function. Excellent point.
Yeah, thank you, Trista. Just to note, no surprise, unpredictable, uncontrollable external conditions are impacting the work that we can do, and quite frankly, exhausting us with trying to track all the different things that are happening. We will continue to do that, but it has impacts in our FY26 budgetary headwinds, and we'll, as presentations continue, to talk about some of the specific impacts, but these are where we do have large impacts. Both in reductions in grants, as Trista talked about, eliminated or reduced access to federal data systems, surveillance systems, as well as clearly any potential impacts to Medicaid. I'll continue this theme in the next slide that's really talking about some of the challenges and our responses. The health department stood up a federal administration planning and response task force that's working with the central task force at the county to assess the impact and respond to the rapid and unpredictable changes in either policy or funding that we're experiencing. We are actively monitoring and conducting comprehensive financial analysis to understand as you just saw, where our funding is, what the impacts are in terms of staff, in terms of community partners, in terms of services, and raising those issues up. We obviously challenge with the county's budget forecast, and coupled with uncertainty at the federal level, create just a challenging funding environment. That's obvious. I'll give you a list of the things I'm concerned about more specifically given that context. I'm concerned about Medicaid and Medicare funding stream implications. I'm concerned about weakened emergency preparedness and response systems and disaster-related expenses. Concerned about federal fund suspensions, denials, terminations, and the like. Increased compliance risks and associated costs for legal remedies that you all may decide to pursue. Concerned about the impact of policy conflicts between federal, state, local authorities and what that means to health outcomes, particularly in areas of public health, outbreak response, a number of safeties, escalation of health information and loss of public trust, going against the work that we're trying to do to educate the public, and ultimately preserving our employees in the face of burnout and the uncertainty and the work that it takes to track what's happening day to day. So all this to say, I am extremely grateful for the investments that you all have and will make locally. I think those investments in the face of all these things are more important now than they have ever been to the health systems that we operate and the health of each and every person. So the next slide, the next number of slides go into kind of the approved budget by division. So if we go to the next slide, this is the Director's Office operating budget. The quick overview in these next two slides is that there's been a significant decrease in funding as it relates to the capital, as Derek mentioned, for the Crisis Stabilization Sobering Center. And the large increases in FTE are really not increases, they're moves. So that's the storyline there. And just shifts in where things are located. So if we go to the next slide, here's some of the significant changes, which include, I made the decisions to align different, as we've talked about ad nauseum, the alignment, the potential of the multi-factorial approach to align certain functions in the director's office. And I'll just say, when this is not all the things to support the director, this is our departmental capabilities writ large that are housed in there. That includes moving and aligning human resources, which is what many other departments and agencies do. It allows us to better support staff, surface issues more timely. We have more concerns, grievances, and a lot of different things that we would like to see. So to be able to have strategies to better support employees and reduce and mitigate those. It also includes the shifting of communications. Last year, we talked about what was called a public health infrastructure grant moving, and that's to make sure that we have the capabilities to do the things that we need to. So communications is both a discipline and an outcome. So that's the shift there. And then, as Angela talked about, there's shifts in the Office of Health Equity, including bringing community partnerships and capacity building, which is our community engagement functions, and to a departmental level that allows them to maneuver to where the community wants, which is not siloed or disease specific, as we know. So that's what they represent. I'll just say, these shifts really reflect my commitment to cross-divisional collaboration, as well as cross-departmental collaboration and innovation. We are one department, and I want my budget and leadership to reflect that, because the communities deserve us to be working better together and to be working as efficiently as possible to maximize the health outcomes that we want to see and that they want to see. With that, I will turn it over to Valdez.
All right, these slides will move pretty quick. Slide 68 really is a quick high-level overview of the administrative capacity lost in the FY 2026 budget. As you can see, we lost analytic capacity, including legislative tracking and analysis, policy analysis, and project management capacity. We've lost key data and analytic staff and expertise, translating data into meaningful information for decisional supports, reporting. Our learning and development team within the health HR team. And then finally, we lost capacity in our contracts and procurement office, cash management and security and administrative support. Next slide. As you can see from this slide, the operating budget and FTE of the operations division is reduced in FY26. However, not all the reductions are due to the FY26 budget constraints. Significant portions of the work are not impacted, but again, as Rachel just touched on, it's been realigned into the director's office budget, though I will still be working very closely in supporting those teams, namely human resources and the communications and marketing team. Next slide. This slide illustrates the reduction in operating budget and FTE of the Finance and Business Management Division as a result of the FY26 budget constraints. So you can see that there is loss here, and that is not due to realignment, that is due to constraints. All right, next slide. And then in terms of how the budget delivers, our administrative divisions are really critical to the success of the health department. As the director, Rachel holds that statutory role of the local public health authority, and her team supports all of us in this work. The health department supports behavioral health division in their role as the community mental health program. And the director's office really provides executive leadership and strategic direction for all aspects of the work. Rachel, as our director, is the convener of the departmental leaders and works to foster that culture of the workforce. And really to operate as a one health department, it requires connective tissue and infrastructure to maintain the open lines of communication, infrastructure offering shared supports, and really a team that aligns our vision and strategy with day-to-day operations across a very diverse set of work portfolios. Next slide. We liaison with other local, state, and federal entities, and our administrative divisions really collaborate with nonprofits, health systems, and other agencies in our shared commitment to improve health. And again, the director's office at the executive team supports divisions in the core capabilities of equity, communications, policy, and partnership development. Next slide. And then our finance and business management division develops the department-wide budget, oversees contract management, works very closely with county partners to carefully implement financial policy, collects millions in revenue, and oversees each division's financial analysis and grants management. And last but certainly not least, the operations division provides that operational leadership and support to all divisions. Next slide. As we look at the director's office reductions, again, the director's office lost significant capacity in policy analysis and planning, strategic planning, and coordination of external partners such as the Oregon Health Authority and the coordinated care organizations such as HealthShare. And additionally, when faced with having to make reductions in operations, we had to really use a criticality index of HR functions, which was used because there are all core functions, but as a result, the department chose to eliminate our staff's learning and development functions within the Office of Human Resources as a result of that criticality index. All right, next slide. And then, anytime you want to make a reduction in infrastructure, or that you go to make it, might not want to, but you make a reduction in infrastructure, it's the internal customer or staff who tend to feel that impact the greatest, though the rippling effects inevitably indirectly affect the community. So when faced with having to meet that FY26 budget constraint guideline, we really did use that criticality index of functions and roles to assess the mission essential functions across all operations. In the end, despite it being a very tough decision, it was determined that the health data and analytics team and HR learning and development team were the least highest ranking in that criticality index. The loss of the HDAT will affect our ability to take raw data and translate it into meaningful information for decision support, compliance and reporting, and our ability to make our work measurable and visible for monitoring ongoing progress and operational excellence. The loss of our learning and development team will have an impact on our retention rates and likely our ability to recruit as well. The learning and development team has traditionally conducted both stay and exit interviews, assisted with new hire orientation, fostered and facilitated both in-person and remote training opportunities to include the creation of digital workday classes, and served as the leaders of employee engagement, employee wellness, and coaching and mentoring programs. These functions are lost in the FY26 budget, and the health department will have to rely more on central HR to provide these functions, to contract out for these functions, or simply not to offer these services. Next slide. And then just a quick slide on this one. These funds represent supplemental funding to augment the level of specialized IT supports that various health department projects and initiatives require. So that's our partnership with IT. And I'll hand it to Derek.
Can I just quickly, the slide shows a 1 FTE reduction, but the program offer shows a 5 FTE reduction on PO 40046.
We'll just double check that slide.
Yeah.
I think that is the learning and development line item.
Thank you.
Yeah, good catch. Derek.
Thanks. I just want to call the reduction in FBM. Next slide. And this reduction will significantly impact the division's capacity to effectively carry out the business operations of the department. This 7 FTE reduction directly impacts our core business functions in contracts and procurement, accounts payable, cash management, and grants management. And with that, I will pass it back to Director Brink.
Is that an $18 reduction?
It's a very,
And can you please outline the effects? That's right.
Nice catch. All right, next slide. So that's what we have for you all today in the department overview. We've definitely certainly taken down questions, but are happy to entertain additional information that you'd like to understand from us.
Just one thing, I know that we don't know about the state pieces in particular, but I'm curious if you have, with the nurse family practitioner and any opportunities with the Momnibus package at the state to kind of backfill that. Has there been conversations, or is that something that's, we can be helpful in, just trying to figure that one out?
Okay. Yep.
Yeah, and I want to, so I just want to remind the board, we have over 5 hours of more of work sessions, budget work sessions for the health department. Just this week. No. I think that's great. So, but I just like, even just this week, we have over 5 hours, and we're planning on inviting the health department and all the divisions back on the 29th for any follow-up questions that we don't get, or that we don't get answered while they're presenting this week. So again, this is like the overview, and we'll be able to delve in. I know Rachel's been taking notes, and Christian's been taking notes. We do have corrections health that is going to be presenting right after this. So if folks have questions they want to get on the record, that's great. And then we can look to have follow-up for those so that we don't run out of time for corrections health today.
Can I ask as a follow-up to get an explanation of the federal cuts to our STI clinic?
So in addition to just getting our questions on the record, are we going to have time for discussion?
I hope that we'd have time after the corrections to, I want to make sure we get to,
Okay.
yeah, today.
Can I get my questions on the record then?
Please.
For the slides. So on slide 18, it's the 4 pillars: prevention, harm reduction, treatment, and recovery. I'm wondering whether you have specific goals outlined in each of those that we would be able to measure how successful we are. And then with the goals, I'd be interested in what is the current gap in sort of between our goal and where we are. For example, the easiest one, like an easy one would be like treatment. It's like, we know we need X number of treatment beds, and and our goal is X, and here's the gap, and then our goal is X with this particular budget. Just while I'm on the slide, harm reduction, are there any funds in here for foil and straw distribution? Thank you.
I'll just say now, no.
Okay, slide 29, a similar question about our specific goals on health equity. So, for example, in slide 13, which is the checkerboard of the leading causes of death, like, would our goal be that they're the same in all sort of disaggregated populations? So just to understand, like, what are our goals in terms of health equity, and if it's possible to do it in sort of whatever the major areas from birth to death. Like, here's what we're trying to achieve in terms of health equities, say, with infants, and then like I don't know how to say it anyway. The way that people die, do we want it to be equitable, or what is the specific goal? Does that help me understand? Like, are we making progress in places where we're not? What are our strategies? Then on slide 33, this is the who we serve, and I asked before, it's like this kind of falls into with the recent decline in population. Are we serving fewer people, or are we serving more people just given the circumstances? So a little bit of like trend. We've got that. I love getting the numbers, but like, where are they in relation to where we currently are? And on slide 48, this is more of a discussion. It's a question, but more also a discussion item, maybe when we get to homeless services. But it says program offer 40069, behavioral health crisis service, $1 million, and a shelter team of counselors and peers who provide supports to 12 shelters. And that seems super thin considering what we know the needs are. So a bigger question is like, is that all the investment? How are we, how are we possibly serving all the individuals we know need services? And maybe it's somewhere else. So just, again, it's a question, but also a potential discussion point. And then my last item is on, this is, again, maybe like what the commission could do to be helpful is on slide 64, the challenges in response, the escalating health misinformation. And I see Multnomah County has a unique role in consistently providing evidence-based health information to our community, especially with whatever equity we have with the community in terms of being a trusted communicator. To like, how are we elevating at that in this particular time? I know we do that like just regularly, but it seems more important than ever now to do that.
Yeah, to quote our communications marketing manager, Diego Basabe, the messenger is just as important, if not more important, than the message itself. So that's a good point.
And then this is maybe just for discussion. I would like to know that coming out of the 90-day fentanyl emergency, which was very focused on downtown, but the data showed that 122nd and Burnside has just as big as issues as 3rd and Burnside. So I'd be curious sort of what is in this, potentially in this budget, that takes the strategies that we felt worked downtown and how they are distributed across the county. And then the last thing, and then I'll be done for this topic, but I wanted to put an amendment on the table for, and then this relates to tomorrow, but we've already had a discussion about it. It's on school-based mental health services and the mental health consultants that provide the lifeline for our most vulnerable and marginalized students in the county, and they're disproportionately located in schools and districts in East Portland and East County. So I'm proposing an amendment which will be co-sponsored by Chair Vega Peterson that restores the $696,313 for 4.18 FTE for school-based mental health consultants. This program will generate revenue projected to be about $250,000. And it would also be offset. In addition, part of the offset would be reducing one identified new position. This is in the sobering program offer. And also in that same offer, the proposed new contracted services in the health department's budget. And I'll distribute copies of the amendment to the commission, to the commission staff, so you all have it.
Thank you. Thank you, Commissioner. Commissioner Jones-Dixon?
Yes, this we would like to look at the CBAC recommendations, so we'll be circling back with you with additional questions in addition to what I've already asked as far as the program offers. And then piggybacking off of Commissioner Brim Edwards, her remarks, just really curious to look at, I know East County, the numbers that we looked at before, as far as our health outcomes, they're drastically lower than the west side. So just like to know how the budget reflects, how are we addressing that more specifically, so drilling down on those efforts. So, thank you.
Any other questions to get on the table?
Yeah. Can I ask for when our behavioral health unit comes up, their analysis of how appropriate people who are experiencing a mental health crisis, their use of congregate shelters and what alternatives we may have for them. I'm also curious about some of the other SPMI-related programs. One of the things I'm interested in is around our treatment capacity for dual diagnosis. And then whatever we've done where we have looked at the work the Oregon Health Authority paid for related to system capacity and where we're at, and what are the plans for ourselves and our partners to have an adequate provider base. Thanks.
Okay. Thank you. Well, I want to thank,
Oh, sorry, I had
oh,
a couple.
you have some more? Okay, go ahead.
On program offer 40046, I'm interested in kind of what each FTE does and what are the comms activities. And then program offer 40041. I'm not clear if we're talking about, there's kind of this other conversation happening with assessing Medicaid billing, and I'm not clear if there's additional staffing that would be needed here to execute if we did a billing hub for PSR, all of those sorts of pieces that I think we've talked about, and maybe we need to wait for that report, but I just don't want to lose track that there may need to be something additional here if we're going to do this other type of work to further leverage Medicaid. Thank you.
Sure, go ahead, please.
So on slide 18, the program with the fire department, is that the chat program? Yeah, it's slide 18, I think it is. The EMS.
Fire department is starting Sorry about that. So yeah, when the fire department shows up, with that medical response, if somebody has been experiencing overdose and we, were able to save that life, reverse that outcome, offering them and immediately getting them on board with buprenorphine has proven to be a really effective way to have, studies show that for a good chunk of the population, I can remember the percentage, 30 days later, they're still on boob and still in, treatment. So
that is the chat
that's what
program.
that is, yeah.
Okay, it is the chat program.
Well, I don't know, is that the chat or is it all fire? I think it's all fire medical response. We'll have our health officer speak to it.
Includes that, but this was meant to, sorry. This slide was meant to show more broadly the work that we're doing in the EMS. So, but we can have them share more about chat when they come back on Thursday or whatever. Yeah. Wednesday, this week.
Okay. Thank you all very much. Really appreciate all of this. I want to invite corrections health folks up. I think we originally had about an hour and a half, an hour scheduled. No, we had an hour and a half scheduled, but we're looking at about like an hour and 10 minutes now. Although you have fewer slides than this one, so hopefully that will still allow us time for our conversations.
Question. Are you restoring the limited duration counselor as well, or no, in this?
It's so Mike.
I'm sorry, which one are you referring to?
Of the mental health consultants,
Yeah.
there were, the FTE reduction of permanent staff is 4.18, but there is also one limited duration, so I was just questioning.
So I'm just doing the 4.18.
All right. Good morning. Welcome, everyone. It's great to see you. I'm going to go ahead and turn it over to you to kick us off.
Good morning, Chair and Commissioners. My name is Michael Crandall. I'm the relatively new Corrections Health Director. Been here for about 4 months. I go by he, him, his pronouns. And I'll let you introduce yourselves.
Good morning, Commissioners. Good morning, Chair Vega Peterson. My name is Tony Gaines. My pronouns are he, him, and I'm the Deputy Director of Corrections Health. Good to see you again.
Good morning, all. My name is Lori Dolo Scott. I'm the Director of Nursing for Corrections Health, and I go by she, her, hers pronouns.
So As we start out this morning, I want to thank the commissioners for keeping our budget held harmless this coming year. I understand how much of a pain that is across the county as a whole, and I truly appreciate your investment in us by doing that. Also wanted to note that in my first 4 months in the job that I have obviously been assessing our team in Corrections Health, and I'm extremely impressed by the dedication and the professionalism of every member of our team. They
Thank you.
are
Can you move the mic a little bit closer?
closer.
Maybe a lot closer. Yeah, there you are. Thank you.
Yeah, I'm truly impressed by the dedication and professionalism of our Corrections Health team. Next slide. So this slide just gives you a quick overview of the things that we'll cover today. And go ahead to the next slide. So I want to start out with why we do the work that we do with our next slide. Corrections Health, our goal is to provide patient-centered healthcare and transitional services for those who are incarcerated in our jails and or involved in our criminal legal system. Next slide. And the focus here is that Corrections Health is public health, because everything that we do affects the community at large, because all of the people that we see, hopefully at one point will become members of the community again. And we want to make sure that when they get out of our facility, that they're one step closer to being healthy and contributing members of society after they leave our care. Next slide. For the individuals that we serve, we have a variety of services that we offer, just to kind of orient you to that if you're not familiar with it. I know you saw this at our downtown facility recently, but we provide a good array of mental health, physical health, vaccinations, dental care, medication, chronic care, palliative efforts, radiology, x-ray. Obviously a wide range of services. There are some services that obviously we can't provide, and in those cases, we would organize or coordinate for specialty care at one of our community partner healthcare organizations. Transitioning to what we do, Tony will take over for the next few slides.
We work across primarily, I'm sorry, next slide. We work across primarily three sites. Our Multnomah County Detention Center, which is located downtown on Southwest 3rd. Our Inverness Jail, which is out near the airport, PDX, and also the Donald E. Long Juvenile Justice Center, which is near Northeast 68th and Gleason. Next slide. One of the things I think that's really important is also to recognize we serve, as Michael said, Corrections Health is community health, and we serve approximately 18,716 community members annually. For this current calendar year, that translates into about 6,083 intakes for adults and 149 intakes for youth. And throughout 2023 and 2024, as you see at our adult facilities, for 2023, we served a little under 16,000, and for 2024, a little over 18,000. And for our youth, that number went down in 2024. There are reasons tied to that. What Clackamas County, with the loss of the Clackamas County and Washington County contracts, contributed to a reduction in our youth intakes. Next slide. Our program highlights and success. Corrections Health Nursing Care is unique to other healthcare settings and merges several distinct nursing disciplines. As many of you know, we are very nurse-centric operations here in Corrections Health. But with that, there's increased exposure to risks, accessibility challenges, providing care coordination, this is wound care that we do, substance use treatment that we provide, and we try to be very trauma-informed considering the population that we serve in our community. Next slide. We have focused we have focused on staffing necessary to providing high-level quality care. One of the things we've really focused on this year is standing up our MSR, or Medication Supported Recovery program. We've added an addictions medicine doctor and 6 LPNs, licensed practitioners, practical nurses, for a total, if you add both of those roles up, all of those roles up, to a total of about 4.9 FTE. We've also hired, for the first time, we have a fully hired leadership staff. So we now have Michael Crandall to my left, who's just started with us, and Lori Dolo-Scott, our Director of Nursing. And also Richard Bruno. Dr. Bruno's not here with us, but he's filling in interim right now for us. Yeah, we have a full leadership staff for the first time in a long time. So that's been great. Next slide. Some of our successes, one of our most recent successes, some of you all may have seen this press release that we're really, really proud of, and I want to attribute this to our staff. We couldn't do this without them. A lot of times when it comes to audits, it's the work that you do beforehand that shows up by the time the audit occurs. And so that work has to have been done before you get there. And so this is a tribute to our nurses, our providers, our mental health providers, our leadership, our senior OAs, our OA staff, our operations leadership. All these folks contribute to us getting 100% accreditation compliance rating from NCCHC. I think, there's a lot of different news articles that come out about corrections and corrections health, and we want to make sure that we highlight this as a very prominent one. It just speaks to the level of care and the level of dedication that our staff provides and is doing on behalf of our adults and youth in custody, and those that are justice involved. So this is really a really important slide for us, and we take a lot of pride and credit in it. So with that, one of the things that comes up for this is having a 86% reduction in mortality. When you're NCCH accredited, these are some of the statistics that show up or can show up when you are accredited and you're following the guidelines and rules and regulations of NCCHC. A lower recidivism rate and also improved quality of patient care and treatment. Next slide. I'll pass it back to Michael.
Now we're going to talk about how the work. Thank you. How we do the work we do. Next slide. So talk about a few of our goals, the status, the strategies for these. The first goal is that the adults and youth in custody within our 3 facilities will have access to safe, timely, effective, equitable, efficient, and patient-centered care. Strategy is to provide ongoing support for the over 1,000 adults in custody and the roughly 35 youth in custody each day. Next few slides will talk about strategy. Strategy with that, like I said, is providing care in accordance with those NCCHC's guidelines that Tony was just talking about. We recruited Lori as our Director of Nursing. It's the first time we've had all of the leadership positions filled for quite some time. We have been very successful this past year in hiring corrections health nurses to help fill the number of positions that we've had open, that we still have open. Our reduction in mandates has shown because of those hiring methods that we've had. We still have mandates, unfortunately. We're still working to reduce the number of mandates. If you look at first quarter of this calendar year, last year we had 134 mandates. This year we're down to 105. So the number is going down. Still nowhere where we want to be, obviously. And then through second quarter last year, it was 236. But granted that we're about 6 weeks away from the end of the quarter, but we're only at 150 so far for the second quarter. So we're doing better. We're not where we want to be, but obviously that's important work because that leads towards the burnout and the cost and everything that's involved with all of that. Tony already talked to the next 2 slides, so I'll go to the next slide. Part of our outcome also, this says average number of health and physical assessments, but it's really the percentage that are done within the 14-day. In 24, our baseline, it was 86%. In 25, our goal was to get up to 90%. And then to keep that target for 25 and 26. There are some individuals that refuse to participate in the process, so we're never going to get to 100%, but we try very hard to do it on everyone possible. And then the average number of mental health evaluations for Suicide Watch. I do want to note that 250 means the goal is that we do 100% of everybody that we identify that needs a mental health evaluation is completed, and that means that we're reaching about 250 is our target number for that. But that number, as you would expect, is probably going up because mental health and illness obviously is on the rise across the United States.
Can I ask a quick clarifying question? Who is doing that mental health evaluation? Like how in depth is it? Is it a clinical, like a PhD psychologist, or is it a nurse doing a kind of rough triage? What's the level of assessment?
Do you want to answer that?
We have our QMHP staff doing that assessment. So it's clinically qualified folks in our mental health area.
Qualified member.
Okay, well, that's a broad term. Like, what type of licensure? There's a huge difference between like a marriage and family therapist or a PhD psychologist or a psychiatric nurse practitioner. Can I get that information?
Sure. Happy to get that to you. Next slide. So the next goal looks at individuals in custody experience opioid addiction so that we can have reduced overdose and withdrawal effects through the availability of medication-supported recovery, including Suboxone and methadone administration and long-acting injectables. The strategy there is to make sure that everybody that's in custody has the ability to transition and protect them while they're in our care. Next slide.
Just a quick question on this one. What is the strategy for continuity of care post-incarceration?
Post-incarceration?
Yeah, well, we're going to talk about that a little bit more in our slides. Yeah, great question.
So we will definitely answer that question. So it should be on slide 18 now. Part of the goal, we hired the addiction physician and the LPNs to help support the opioid use disorder cases to improve our overdose response within the jail settings and try to make sure that individuals connect with medication-supported recovery services in the community. We hired the physician a few months ago, about 5 months ago. She's been very, very helpful and very aggressive in getting all of this implemented. And I guess Tony will keep going with the next slide.
Yeah. So another one of our strategic goals is to provide medication-supported recovery training at all sites by the end of 2025. And this is ongoing and on schedule goal. We're going to work with the State Opioid Treatment Authority to initiate a methadone treatment solution in adult settings, which we are currently engaged in, and significantly increase communication in partnership with Sheriff's Office to ensure the approach is in alignment. We also partner with OHSU and other community partners, so this is also a part of our strategic plan and our broader overdose response as well. Next slide. Another goal is to apply for grant funding to support Corrections Health, the MSR, or Medication Supported Recovery and Long-Acting Injectables program. For those of you who are aware of this much-needed medication, it is very costly and very expensive. So we try to seek out and search for any grant funding that's available in order to stand up this work and support this goal of ours. For example, one of our outcomes is in November 2024, we awarded the Bureau of Justice Assistance Grant, which totaled approximately $660,000. And as I think Tristan mentioned earlier, there was the opioid settlement funds in which Corrections Health was given $490,000 of that money.
This next slide shows the level of deployment of naloxone in our jails. And in July and August is when our program really went into effect with MCSO. So you can see how that obviously took effect right away with how often we were having to deploy naloxone within the facility. So the training and the implementation is showing some effort, obviously. On to the next slide. The next goal is that individuals transitioning out of custody will experience reduced recidivism due to comprehensive wraparound transition planning. That includes everything from case management, medicated supportive recovery, connecting them with healthcare. There was a recent study that showed a strong correlation between if an adult leaving custody has housing, reduces the rate of recidivism. And so obviously that's something that we want to try to focus on as much as we can. Next slide. With the grant that we secured from the Criminal Justice Commission, we've helped to integrate care into the ICS health centers for our patients to make sure that they're, have continuity of care, that we make them appointments, we get them set up with, primary care, that kind of thing. Our TSP, Transition Services Program, does provide the medical and mental health support and care coordination for referrals, for housing, for treatment, for distribution of supplies that are needed. They also will register them with both long-acting injectables, Sublocade, Paroxetine at both adult sites. This next slide just shows a display that our TSP staff put together. Good, there you go. That they set up on their own initiative in the DC facility downtown to just help educate staff and visitors and MCSO staff for education and awareness related to the important issues. Next slide.
So I want to jump in here because I'm hoping this isn't the entirety of where we want to talk about continuity of care post-incarceration.
Right.
I don't think this is just you all. I've had the same conversation with the sheriff's office, but it seems like we're missing opportunities to link even just outside of the health department. So I'm curious what other either county services or departments are pulled in. What are the referrals and what are the success of the referrals? This is something that we may not have the data for now, but I want us to figure out how we stop releasing folks who may have other needs that they can get connected with supports. And it might be easier through health than it is through the sheriff's team. So I'm just trying to figure this out because we haven't figured it out yet in this community.
Okay. Don't have the answer to that today, but we'll definitely work on it.
We did just try, we just did one person that we connected with ICS who is on a long-acting injectable. And one of the bridges into that, one of the things on our side is not having a crystal ball of knowing exactly when they're leaving, and then ICS having the exact time that's going to connect them to primary care. So I know they're looking at, on their side, a little bit more nimbleness of being able to receive them. I was just in a meeting about this a couple days ago. And so we're definitely in the conversation about how do we bridge this so that there's an easy way to get them connected. And is there a way even for them to meet them ahead of time via tablet or something like that, so that they have even a face, so that they're a lot more likely to follow up because they've already met the person and they've already gotten a connection there. Because we know that that's a lot more likely to have them show up for that appointment.
Yeah, I totally appreciate that. Thank you for sharing that component. And it may just be something that we want to keep talking about over time outside of the budget process, because I completely agree. And I've started the street mental health outreach and had a prescriber who was doing injectables in the field for folks, and it was a game changer for people. And so I just want to take those opportunities and make sure that we're doing the linkages that we can. Again, it's no one department or one program's responsibility, but we're just kind of missing that. If they touch the county, I want to help them figure it out, as opposed to them have to figure out how to navigate all our different services.
One thing I will say, and this is something that we can also delve into when HSD comes back in the homeless response team, the inflow to homelessness from carceral settings is part of the HRAP. And I think that's part of the body of work that we're looking at really delving into as we look at the additional goals that are in the HRAP and how we're implementing those both here at the county and with our other partners as well. So I think this is a really good, important part of the conversation.
And I would just add, Chair, I think part of it is it's not just the inflow. I've said this many times. A lot of times workers in homeless services are working with somebody and they get incarcerated, and we have the opportunity. We're not taking the opportunity to reconnect them. The staff are left to go find the person again, whether they're in shelter or on the streets. And I think we can do better than that.
Yeah, agreed. Thank you.
Next slide. So this shows the number of individuals that can benefit from participating in our MSR program. It's a rising number that are actually participating in our MSR program, as you can see, based on the percentage of the overall population. And Tony will take this next slide and it'll start to answer some of your questions.
Yeah. So earlier, yes, Commissioner Singleton, yes, a great question, and I think this will speak at least partly to what you've raised. This slide talks about the continuity of medications, the long-acting injectables, preventing overdoses, saving lives by providing up to 30 days of care without requiring any action from the patient. As we know, and this is important because, the highest risk of overdose is the week post-release. We know that. Our data shows that. Also, these medications have a higher efficacy. We've learned that as well. It ensures medication continuation during both entry and release from a carceral setting. So having access to this medication is critical for those reasons. Antipsychotics increase chances of participation post-release services. And currently, that's about 14 patients for us that are engaged in that. And we are working with ICS currently. There's a partnership going on called the Transitions of Care project that we're working on, where we are trying to build a relationship and build a communication system. So there's more of a streamlined effect and where we and ICS and some of our community health partners, our TSP, our Transition Services Program, can serve as a conduit to get people into primary care so they can continue access to long-acting injectables and the medication. So we are diligently working on that. We have meetings with with the ICS regularly. Having worked in ICS for quite some time, I know that there are certain barriers that we have to navigate. Many of you know that ICS sees patients who are residents of Multnomah County. They have to establish care with them. So there's some minor challenges that we have to figure out and how we can honor that system but still get people in. So I think that those are some of the things that are definitely on our radar that we're looking at. So hopefully that speaks a little bit more to what your question was. Yeah. With that, I'll pass it back to Michael. Oh, I'm sorry, next slide. This was the slide I was referring to. Sorry about that. Next slide.
So part of how our budget delivers with our transition services program, they do a lot of referrals for, they go and meet with the AICs and assess what their needs are from talking to the individual and figure out what they need as far as any kind of basic needs, with hygiene and medications, continuity of care, housing, employment resources, the harm reduction or inclement weather supplies. If it was somebody that was taken into custody in July and they're getting out and they only have, warm weather clothing, they need something to be able to stay warm when they walk out of our facility. And so we provide, clothing, that kind of thing. Do they need a bus voucher to get to the shelter, to get to their appointment, to get to meet their parole officer or whoever it is that they're needing to meet, with any of the community partners? We provide that type of material. So it's any of the things. It's really just assessing what each individual needs and trying to meet those needs. Next slide. Again, trying to increase that cooperation and integration with the Oregon Health Plan, with the enrollment, and then the re-enrollment when they get out of our services. We work on providing gender-affirming care, and we've just recently also, we're excited, we've applied to participate in the Zero Suicide Academy as part of a recommendation from the interagency. We're waiting to hear back if we were approved, and with that will come a little bit of money, but we don't know how much until they decide how many people they're approving, that kind of thing. We'll hear back on that this summer. Next slide. So just, some of the challenges that obviously we face in our environment is, behavioral health acuity and complexities on the rise. And depending on who you listen to, probably give or take 60% or so of all of the adults in custody have some type of behavioral health issue, in addition to potentially having medical issues. Healthcare costs and medical complexity obviously just continues to rise. Pharmaceutical costs continue to go up. The cost of, the continuity of care medications goes up, because if someone comes in on medications and they need those long-term for, diabetes or heart or other medical issues, we make sure that they leave with the supply of those medications. That's costly, but it's also helps to keep them healthy until they can transition back to whoever they get care from. And then, of course, our staff overtime is not ideal because we're still short nurses primarily, and we have a reliance on agency staffing that we're working on overcoming. Next slide, continuing that conversation. So in response to those challenges, we're creating a pharmacy committee so we can look at the types of medications we're using, see where we can provide lower cost options that are proven similar efficacy and quality, to potential participating in the 1115 waiver so we can get revenue for the types of services that we provide. We've hired additional mental health and transition services programs that have skills assessment staff so that they're focused on the culture and makeup of our population more effectively. Focusing on utilizing our correction health partner so that they can do a better job with our patient care coordination and management. We're still building capacity in our transition work and our quality team work. And like I said, developing critical partnerships and seeking grant funding. I think one of our focuses of the leadership team, of course, is filling our medical director position that you probably have heard is vacant. So Dr. Bruno is our temporary assist, and he's great, but he's not our long-term successor, obviously. So we'll continue with that search and, really trying to build our corrections health culture so their team members feel like they're heard, they're respected, and they're real proud of the work that they do and that they're proud of being a part of our corrections health team. Every place I've been, my goal is to turn my team into the employer of choice in the local community. And that doesn't just happen overnight, but it's really important to have an engaged, effective staff. And we can definitely do that with the team that we've got on board now. I think for us, for our team, if we were going to come back next year and talk about success in the next year, success to us would be, of course, hiring that medical director, but also stabilizing our staffing, creating and tracking quality and care benchmarks. We're sorely lacking in some key performance indicators, and so we're building systems to create those so we can better provide you back, data on the types of services that we're providing for our population. Also want to have a fully implemented MSR program, continue to grow our partnership with MCSO and our JCS partners. And last but not least is most importantly to have the consistent, respectful, and excellent healthcare and mental health and substance abuse staff that support our adults in custody to make sure that they're getting the type of equitable, safe, effective care that they need and deserve. Transitioning to our budget discussion, the next slide, the actual numbers. So $35.4 million budget, 145 FTEs. Go ahead to the next slide. So this really kind of talks about the process of making your decisions, taking the chair's guidance and direction, aligning those with our health department mission, vision, and values, and then working to reduce the preventable deaths within our four walls, working on achieving health outcomes that transform the system, any inequities that we find to close health gaps, those types of things, applying best practices to support our work, to maintain the excellence and the accountability, maintain and retain the expert workforce, focus on building the culture, like I said, where people want to come to work and they're proud of where they work, and have a little fun when they work. Addressing community priorities, responding to the community's evolving needs, and then just preserving our unique role with the government. Next slide. As far as equity, what populations does our department serve? We've really focused on culture and language using known related skills assessment for both our mental health and our provider teams. That's something we preserved in our budget. We recently just hired a mental health Black KSA counselor who has carceral experience. He's going to be a great member of our team. But just doing things like that and just using our existing vacancies so that no one population sees any kind of reduction in services or access to the care that they need. Next slide. This shows last year to this year's transition in the budget. The difference from 25 to 26 is really based on inflation because our budget is held harmless. The number of positions has grown up a little bit. That's because we took the higher expense of a few nurses that make more money and reclassified those into LPNs for the Medicaid, medically supported recovery. So that's why there's a little bit difference in that. Next slide. This shows the cost of healthcare that has gone up for our, with the FTE trend. In 23 is when we had our strategic investment in the RNs and trying to really boost that. And that's why you see there's a big jump in 23. The next slide shows our budget by the different programs. So you've got the downtown facility, the Inverness facility, our corrections health, our health admin team, transition services program, the juvenile detention home, and then our dental program. The next slide shows how our operating budget breaks out by category. Like any healthcare organization, that provides actual hands-on healthcare, the preponderance of our budget is our people, all of our team members that provide care, because that's the bulk of what we do. The second largest slice of the pie is primarily related to the medications because the cost of medications is so expensive. Next slide. This shows how our corrections health funds have grown year by year. Our operating funds have grown for the year, over the years. The next slide speaks to the reallocations that Tony spoke to in a few previous slide, where we grew the medical support recovery program and added the physician as a part of that program, shifting the vacancies to support our growing TSP needs and services. Tony will take over on the next slide.
Yeah, one thing I want to call out real quick with these next slides, even though these are Oregon legislative updates that we're providing, we don't anticipate these having any impact on our budget or us having to make any budget changes based on this information. But so I just want to make sure to call that out. But also want to bring recognition to some of the legislative items that are out there that impact our operations and what we do. So House Bill 2506 directs the Alcohol and Drug Policy Commission in collaboration with OHA to develop statewide policies and practices to support the availability of medication in OUD or opioid use disorder in physical care settings and the transitions to care in the community. Right now, this is in House Committee, and again, we don't anticipate that this will impact our budget, but truly unknown at this time. So, next slide. Next one is Senate Bill 171, defines dangerous to self, dangerous to others, and serious physical harm for purposes of involuntary committing a person with mental illness. Again, right now this is in Senate Committee, and same thing, unknown at this time, any budget impacts. Next slide. Senate Bill 293A. Requires the Department of Corrections to provide certain medical care to adults in custody and document the reasons for any denial or refusal of medical care to adults in custody, and refrain from considering the remaining duration of incarceration for adults in custody and determining medical care. And again, this is in Senate Committee. Next slide.
So this refers back to that criminal justice. This refers back to the Criminal Justice Commission, that 1.1 grant that we received, working on partnering with the opioid treatment provider to expand medication options that we have for adults in custody in both of our facilities, and the funds will be used, the funds will be added in an upcoming amendment. Next slide.
Sorry, just to clarify, the amendment will be for FY26 budget for the CJC dollars or the current budget, or both?
Both. Part of it's, we have a small
25.
part
Okay.
this year and then some the next.
Okay, thanks.
Shifting to the 1115 waiver, that's a shared program that we have between Corrections Health and the Sheriff's Office. And basically, the bottom line is it allows us to bill for the services that we provide. We were slated originally, oh, you should be on the next slide, sorry. If we were originally slated to start in January of 26, it looks like the latest news is that's been delayed for at least 6 months, if it is going to start at all.
No, this is not you.
Well aware. We feel the same frustration, so. The point of this is to build capacity for the Sheriff's Office to be able to provide for the substance abuse that they care that they provide, but then also for us to be able to provide for our care. And it allows for the Oregon Health Plan benefits to continue while they're incarcerated. For us, the money that we would use with that is really building our ability to focus on billing and coding and, having that type of service, because we don't do that in today's world. We use Epic, but we don't use Epic in the billing coding world. And so we just need some expertise, that kind of thing. And a little bit of credentialing that Medicaid requires. But it's not something that any of us have not experienced in our past lives. So we have the experience. It's just growing the infrastructure. The next slide. Continuing with 1115, it requires transitional services, which will speak to some of the things that you all obviously have a heart for, which is great. It does require that we're supposed to start that 90 days prior to release, which is a very hard target for us to target sometimes, because we honestly often don't know when someone's going to be released or find out on short notice when someone's going to be released. So it's challenging. That's not on our side of the fence, though. It's probably more of a court thing than it is an MCSO thing, honestly. It will increase the number of adults in custody that can participate. It'll help us to provide additional services during the mental health assessments. It will also require us to provide 30 days of medications upon release, but that hasn't really been defined yet, whether we're actually providing them 30 days of actual medications in hand, or if it's, arranging for prescriptions. The prescriptions would be far safer and far less costly for us. So that would be our choice if we're given the choice, but I don't know that we'll be given a choice in that. Because sending an adult in custody out with whatever 30 days of whatever medication on hand is just setting them up to be stolen or misused, that kind of thing. So it's sold on the street. I mean, there's any number of bad things that can happen with that. That's the last of our formal slides. I do want to note that I'm really excited about a month and a half or whenever it is that y'all will come out and see our Inverness jail, because we just finished remodeling our section of the Inverness jail, not the actual treatment area, but the place that we call home within IJ. It's beautiful. The staff are loving it. We just moved in a week ago into the new area, new carpet, new desks, new ceiling. Like it's really pretty, and the staff are very excited about it. So we're, it's nice when you move into a new home, because then everybody's excited, and it really ups the level of morale for the staff there at IJ, which is great. So very excited and happy that was able to happen for them.
That's great. Thanks for sharing that news. So thank you also for getting us back on track with time, with going through the slides. So I want to open it up for folks who have questions for you, and I'll just open it up to the board. Please go ahead.
I see that you have 48 vacancies in corrections health right now, which is about a third of all positions. What strategies are you using? What is your plan to try to recruit the needed health professionals? And what is a realistic goal for how much of these positions we can actually fill in the next fiscal year?
I'll tell you, I'm going to intro and then Lori can talk, but we're doing things probably different than they've been done. And I'll let Lori speak to some of the nursing, because Lori and I think very similarly about a lot of recruiting things, because I've taken on recruiting challenges in my past life, as has Lori. Lori can speak to what she's doing on the nursing side. Go ahead.
Yeah, so I will say that we have a weekly block on the calendar for anybody who meets minimum quals to come through panel interview. So we have it blocked. There is no barrier to access the panel interview. I can tell you that. I can also tell you that about 11% of the people coming through the door don't even show up for the interview. I can tell you that 20% don't show up for the interview or refuse to do the interview. So it's really interesting. When you do the breakdown, I have a pie chart. I could send it to you if you'd like. But of all of the people that have actually applied, we are hiring about 24% of them. We're only declining less than around 20%. That other percentage is folks that either can't pass the background check or aren't showing up for the interview. So it's a really interesting marketplace right at the moment. Active-wise, the nursing staff and I are planning on doing a road show around the nursing schools, because one of my hypotheses is that corrections health is not widely known as an option. I didn't think about it in nursing school. It wasn't part of my public health options when I went through U of P. And so for different people who've graduated from some of the local nursing schools, I'm pairing up with our frontline staff to go out and do speaking kind of dog and pony shows out there in the nursing schools to talk about what the opportunity is in corrections health. And I don't know if you're from here like long term, but do you guys remember the pink glove dance that St. Vincent's did way back in the day? That it was before the term viral went viral. But corrections health staff, the nursing staff and I have been trying to think about what would be corrections health worthy for getting viral about the awesomeness of corrections health. So we're trying to think about what that would might be that would also pass comms approval and legal's approval and all those kind of things. Nod, 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 awesomeness, attorneys over there. But that would highlight the awesomeness. I had a conversation with one of my staff the other day who just came out of hospital, and she's like, I feel safer here providing care than I did at the hospital. And I think those are unknown things. And so carrying those quotes, if we can, into places where people need to hear it, I think will attract people to us. I'm also trying to have a day in the life conversations with people right after they apply, directly with me, so that I can chat with them about what it's like, to make sure that before they're even coming to panel, they know what they're getting into and that they know what the opportunity is. So great. And if you have other ideas, let's chat. I'd love to chat.
I wanted to know, and this can be a follow-up if you don't have the answer offhand, but what is our ADA process internally for people who identify that they have a disability and the process of accommodating that disability?
Are you talking for staff or for the inmates, or both?
I'm talking about inmates.
Do you know?
I mean, where I've seen it is through the MRF process. They'll bring up something, or they might bring something up when they're first coming in to incarceration through the booking or intake process. They might bring it up through when we're doing the H&P with them. There's several different points through the process where we talk with them about more in-depth things. Some things are obvious, right? Like if they're signing, or if they're mute, or if they're hearing impaired, they'll bring that up to us more early on in the process, where we can provide a tablet or something like that for them. And then we need to work with really closely with our sheriff's partners to say what is kind of allowable in this space. There's a second level that I haven't been as familiar with out in the clinical space that I need to go through with my partners to say, okay, I know it's allowable in, the Providence system or the Kaiser system, but what's allowable here in the jail space?
I bring this up because I am aware of a few ADA complaints that have come from people who are incarcerated in our jail. One is an individual who is deaf and uses American Sign Language. Another one is an individual with autism spectrum disorder who was not believed that he had this diagnosis. I have concerns that it's not a well-documented, clear process. One, the fact that you would bring up a tablet as a reasonable accommodation for somebody whose primary language is American Sign Language. Written English is not the primary language of somebody who speaks ASL. So I have... You have what?
We have somebody signing on the tablet back and forth with them. It's a video conference tablet.
Okay.
So I actually observed this with one of our folks that was incarcerated, where she was signing back and forth with we brought them up almost like you would an interpreter phone, but this was a video conference tablet where they could sign back and forth with the tablet person. And then we had the nurse standing there, and they could have a three-way conversation about what was going on with their care.
Okay, and how available is that to that?
It's right there on the unit. They can ask for it whenever they want to use it.
But I would like to see the actual policy of how disability is identified and the process in which corrections goes through to make reasonable accommodations.
And I think some of that will need to be answered by the sheriff's department too, so we can also make sure that this question gets to them.
Right.
Okay.
And then my last question is, in conversations with the sheriff and others, where are we in looking at how we deliver mental health services to people who are incarcerated? I have some concerns about, one is just having people with severe persistent mental illness in a carceral setting where they are alone in a very small room for extended periods of time. I also have concerns, and this is not you, but I think it is a conversation between you and the sheriff's office, of having corrections deputies with absolutely no experience working exclusively or primarily with this population without additional level of training, and just the overall physical environment being one in which somebody's symptoms are likely to be exacerbated and not get better. So I'm really interested in, now that we have you on board and you on board, where we could go with some work, trying to make sure that while people are in our custody, and unfortunately they're spending longer than they should with us before they get the treatment, I would be really interested in looking at how we improve our behavioral health care, both through healthcare services, but environmentally and others.
So one of the things I just recently learned when we were on that tour with you guys the other day was that some of our deputies are actually trained specifically to provide services on the mental health unit. And so I don't know how deep that goes. I'm going to let the sheriff's office speak to that. But they, Aging and Disability Services kind of came in and did an evaluation of that particular unit and made some recommendations like, let's use some blackboard paint on these walls. Let's give them chalk and an outlet for art and stuff like that, because we were having art with other things. And so.
That was actually Disability Rights Oregon and not our agency.
Oh, okay. Thank you for the correction. So I would say that right at the moment, it is layered, right? We have our mental health consultants that go out and see people on the regular. They're located very closely to the mental health unit. We also have our mental health clinicians that are more the ones who prescribe medication, that are also seeing patients on the regular. We've been trying to recruit a psychiatrist for quite a long time and have not been able to recruit one at the moment, but I know that that's something that we have our eyes on. And I would agree with you that there are times when we're like, this is a rough place to have this person being right at this moment. And we are trying to do the best we can, given the constraints that we have at the moment.
Thank you. Any other questions?
I have some questions.
Okay. Commissioner Jones?
This is a random question. Just how do we, is there an opportunity to actually hear back from the folks that are in our custody about just the level of care that's being delivered and getting feedback from them directly? Is that currently a part of our process? And then to build off of your point, Commissioner Moyer, to respond to your point, I've had a family member that is currently incarcerated. He went through a full psych exam and they actually reached out to me personally out of concern. And even when I had concerns with other family members, I've reached out to the medical team and they were responsive. And I was impressed by the level of care. But could you answer my initial question or respond to my initial question?
We don't do surveying like you would with care experience kind of surveying you'd see in a hospital setting or a clinic setting. It's not to say we couldn't. That'd be possible. But we do get feedback from people through the MRF process of hey, thanks for getting that done for me, or I need a little bit more support in this area, which tells us we didn't quite hit the first time on whatever the request was. So we are getting feedback loops from the MRF process, and that's how we do a lot of our interactions with folks on the day-to-day. Last couple weekends, we got 117 just at DC. So there's a lot of volume of communication back and forth with folks in that space.
Thanks for the presentation. I had a couple questions and just some observations. On slide 9, it's Corrections Health, who we serve. And there's been an increase from 15,000 to 18,000, which I'm assuming is closer to pre-pandemic levels. And I'm wondering, just thinking sort of longer term as we sort of slowly come out of the pandemic and practices are sort of reverting more to the what used to be the norm. When there's an increase in the population, is there a corresponding increase in medical services, or is there like a base level that sort of covers the fluctuations?
There's an increase because everyone that comes through the door has to have an intake has to have an intake with medical. So, and if they're there at least 12 days, they're also having an H&P done. So if one of the things that we were noting towards the beginning of the year was that a lot of people that had in the past been released on recognizance were not being released on recognizance. We kind of had a list of the types of charges that would often be released on recognizance that weren't being released anymore. And the nurses were like, whoa, these are staying, we're seeing a lot more people stay. And people that we would call Clackamas or call Washington County and say, do you want us to hold this person and transport them to you tomorrow? Or do you want us to release them? They were having us hold them overnight and then transport them the next day. So that meant there was a level of care that we were providing.
So I'd be interested, and this is more of a follow-up, not right now, but like what sort of the formula is if there is an increase or the change in the presiding judge's order or people being held, what implications that has versus looking at it as a lagging indicator, but more like when we're here or we see this sort of growth, or changes, here's what we would need to staff up. It'd be good for me to understand, because it's not one of those things where you can just be like, well, we just don't have the staff right now, or
Totally. I was just having this conversation with one of our sheriff leaders the other day. I said, hey, when Portland Police is going to do one of their things, like, let us know, because we need another person down in intake, because we get a bolus of people in on one of their, I can't remember what they call them. I'm so sorry. Is it a project? What is the word? It's a term. Operations? I don't know. Anyway, they do it's not a sweep. I don't know what sorry.
it's like a strike force action where they
Yes.
target.
When they do one of those, let us know so we can put a third person down there in intake so that we can keep the flow going. Like, if you can let us know that that's coming, we'd be happy to like rejigger our staff so that we can keep the flow. So yes, and next year when we come back, I really would like to do an acuity, like I get kind of data geeky and I'd love to like math out the acuity of what that means for you as far as work level, like lift for the nursing based on what's happening with the population numbers.
Great, I'd love that.
Officer Bork shared that it's a mission.
Mission, thank you. I didn't mean to be disrespectful. I just couldn't remember the term.
It's a thingy.
It's a mission, okay.
Or operations,
Got
as I call it. Speaking of data, well, I guess I'm going to first, before I get to data, but since you brought it up, on slide 12, there's the sort of discussion about the accreditation. And this is more just a general comment. I really appreciate that the jail inspections that we're required to do twice a year have included an integrated corrections health and shown sort of, I feel I've had an opportunity to see, like, it's not something like you can just walk into a hospital, it's like you're on a jail tour, but to see kind of how the sheriff's office staff and corrections health are working together, kind of where there's gaps, and what the two departments are doing to sort of better integrate because they're supporting the same population. So I really appreciated that that's been a part of our walkthroughs. I don't know if that traditionally has been the case, but it's really helpful because we read a lot and hear a lot about what's happening inside, and especially when I first got on the commission, it was the year after we had sort of an unprecedented number of in custody deaths. So I just want to share my appreciation for everybody that we talked to in corrections health as we were touring about both the challenges, but also what was working and how this coordination with the sheriff's office was, I think, improving care and support for adults in custody.
Real quick, board members, I want to make sure that I give kudos to you all too for funding the interagency committee last fiscal year that allowed Corrections Health and MCSO to be able to build a better partnership. That partnership already existed, so I definitely don't want to paint it as though there was no communication and, you know, we were like worlds apart. But that helped to solidify some of our policies and see where there was overlap and combine some of our policies so that we're having similar responses to certain situations. So that was just key, and also just the leadership over on the sheriff's side. Our leadership here has just been really hyper-focused on that. So, but anyway, just giving you kudos for that too. Those things go a long way to help us living out our mission. So thank you for that.
Great, I appreciate you saying that because it's always good to know, like when you fund something, whether it's been useful. And I know there's a lot more work still to be done, but I really appreciate seeing, again, that coordination and really getting after something that was very concerning. So I'm going to go back to data. Starting on slide 17, there's these strategic goals and outcomes. And this is like a health department question, but also it's going to be a question I'm asking sort of across departments. And maybe this is part of the big strategic plan work that's happening. But it would be really helpful on these goals. I love seeing the goals and then the strategies. That's helpful to see how you're getting after it. But to actually see some numerical, like measurable goals, so we, again, just know how big the task is and then what sort of progress we're making. As again, as a policymaker, it just helps us like, hey, did we make just a little bit of progress with that big investment, or with a small investment, did we make a bigger? And so I don't know, maybe it got condensed in the slides, or maybe it's not, maybe you have them, but they're just not stated, but I'm interested that, you know, on page 17.
One of the comments that I made during the slides was what we realized very quickly and when we started turning over rocks and looking for data is that there's a ridiculous amount of data that doesn't exist in our world.
Do you say that doesn't exist?
Exactly. And we will fix that.
Okay, so when you're saying it doesn't exist,
It has
like
things
we
that
don't have
haven't,
it or we don't access it, or it just,
we haven't been measuring things that are just obvious things that we should be measuring. So we will work on fixing that.
having been parts of large organizations, one of the great things about having data is like when you make progress, it's great for people to see it because it's very affirming, like keep going. So I would love to see if you, because I mean, one thing is you worked in a somewhat of a closed shop environment, that data should be available, but to understand sort of what the gap is again, and then the goals on the slides where you have strategies 17, 18, 19.
We agree wholeheartedly with you on that.
22. And then this is more maybe making me smarter. This is in the category. On slide 26, long-acting injectables. Like, how does that work? And I'm assuming if they get a long-acting injectable, but at some point they're released, how is that continued, or how does that work?
So one of the goals of a long-acting injectable is a lot of times people who come into our care have at least 2, if not 3 different components going on. And one of the things, one of my dreams to bring back to you at some point is some sort of an acuity measure that measures like what's going on medically, mental health, and substance use across all of those. New Mexico has one, and I want to try and figure out how to use it.
Who has
in
one?
corrections health. New Mexico has one.
Oh.
It could be really cool. But anyway, I digress. Long-acting injectables, lots of times this population is very, they need a little bit of structure to keep them going down the path they're trying to go down. And the long-acting injectable gives them that extra little oomph to keep going down the path because they're not needing to remember to take something every day, right? you get it once a month. And there's a little bit of a window, about a 5 to 7 day window, depending on what you've got them on, that they can take it within. And so if you have a community health worker that's like beside them, like, hey, have you got your bus ticket? You planning to go tomorrow? What's in your way? Let's meet, let's go together. You know, let's get you there. That can get them over the hump, especially if they're about to release from incarceration, as that window that's really the danger window, is if we can have them ideally release, and this is the problem because we don't have that crystal ball to know when they're releasing, but if we give it to them like 10 days before they release and they have a 20-day window or something, that we give them a little bit of time, get them connected with ICS, get that community health worker out with them, getting them there, help and support them. That's the idea, is that they're not having to do that daily remember to take it.
Right, and so when they, say they're released, you're saying ideally through ICS, they would then have an appointment to get another
Dose or another community partner. There's lots of community partners that do LAIs.
And then I guess, and this goes back to data also, if that's the ideal, are we tracking data whether that actually occurs?
Yeah, so we just did our first one, and he's due on the 30th of this month. And so we're tracking to see if we make all the connections.
Commissioner, I just want to jump in to say, I'm not sure that that's ideal for some of the population. And this is where kind of I'm going down the line of how are we bringing those meds to the people if they are houseless still and don't have that, even the person maybe doesn't find them. Just how are we making it easier for people to stay on their medications when they're still struggling with basic survival? So I think there's more there. Not everybody can still navigate to outpatient.
Great, maybe when we see the first batch of data, it will inform.
There's definitely a space for mobile health in there or in community-based care. These LAIs are getting a lot less temperature sensitive, which means you can have them out in the community a lot more easily. So we're getting a lot more options that direction. It was, when they first released, they were super temperature sensitive, which meant you had very few options for them.
I think one other thing, we also have an opportunity, we talked about this with partnering with ICS. We do have community health workers that obviously are in the community that can help coordinate that between someone who's transient, experiencing houselessness and homelessness. So I think there's some opportunities there, but that is a very tough population to really engage with. So you bring up a great question. I think we're still kind of looking for answers, but our community health workers could be potentially a way for us to figure something out with that.
I just thought of one thing. So when I was at CCC, I launched the community health, the mobile health program for them, Backpack and Street Med. Bruno, meanwhile, launched yours. And then we created the Tri-County Community of Practice for mobile health. I'm wondering if that's a space to try and connect with that community of health for mobile health, to see how we can make connections with them too. And since Bruno's still chairing that, that would be a great way to connect them in with us.
Then my last question is, I think, more of a health department question, but it relates to something that, just this topic. So does the health department, when you get in the 4 pillars of treatment and recovery, does the health department have a policy that is biased towards medication-assisted treatment and recovery? And do they, I mean, so I've heard from some providers that are, I don't want to call it abstinence because that sounds bad, but like they're not medication-assisted treatment in the sense that the health department is less supportive of that. I'm just curious whether there's a like formal policy, or like we don't fund medicine assisted or medicant. Is that what you call it? Medicine assisted.
Medicaid assisted therapists.
Yeah, okay. I don't remember what the M stood for.
Yeah, I'm not quite sure I'm tracking your question, but if the question is if the health department is invested in having these positions or having this particular practice in our health environment, we do have those already. I know ICS does, for sure. They
I think the
probably will
question
say
is,
they need
might be for Rachel and the Health Department leadership to talk, because as I understand your question, it's not, are we doing this work? It's how are we not supporting organizations that don't follow that path? Is that right?
That's correct.
Yes, so.
Like Rachel maybe.
So we'll follow,
Sorry,
oh, do
Director
we want to
Vance.
follow up with that?
So thank you for the question, Commissioner Rachel Banks. For the record, we support all forms. Medication-supported recovery is one of those options that work for a variety of people, but also we're supporting providers that other treatment, recovery, abstinence, so the range. So it is not exclusive. We are not biased towards any particular area. This group of folks who are working in the medical setting are talking about the work that they're doing using medication as part of that treatment and recovery option, but we support folks across the range.
Great, thank you.
Yep.
I don't have any more questions, although before we adjourn today, I have one other amendment to lay down.
Okay, and I have a couple of amendments.
Okay.
So why don't you go ahead with your amendment, and I will go with my amendments. We'll move into that. Thank you, Health Department. Thank you, Corrections Health, for a great presentation and a really good discussion.
Thank you. Should I go ahead?
You can go ahead. Yes.
Okay. This amendment relates to the presentation last week of the District Attorney's Office. So Multnomah County is responsible for many elements of our public safety system, and it's important we prioritize and improve the overall capacity to meet the needs of our community, supporting and protecting survivors of domestic violence, ensuring adequate and timely review of body-worn camera footage, and providing individuals a proven path the criminal justice system into treatment are integral to a healthy public safety system. I'm opposing an amendment that restores a total of $1,044,727 for 4 FTE in the district attorney's budget in the following program areas: $222,000 for 1 FTE domestic violence unit deputy district attorney, $617,663 for 2 FTE in technology in the body-worn cameras unit, and $205.64 for 1 FTE treatment court unit deputy district attorney. It's offset by $1,044,727 from 6 vacant county positions. And I'm, in this case, identified positions to offset, but I'm trying to model a potential new practice of providing an offset in working with counties in terms of prioritization of positions. Okay. And I'll distribute.
Thank you, Commissioner. I'll pass it on. Thank you. I have 2 amendments to put on the table. They are both revenue amendments, which means they are adding dollars to the budget for FY26.
Wait, I might have a couple more amendments.
I don't know that they're even covering the one you just laid down, but here we go. So the first amendment is appropriating $545,000 in ongoing general fund that can be reallocated in response to a recent opioid settlement. The opioid settlement revenue will fund programming in a 24/7 sobering and crisis stabilization center implementation. This new program was already funded in the proposed budget, so moving it to opioid settlement revenue will allow the board to reallocate the ongoing general funds that were previously programmed there for another purpose. It will be a departmental amendment that will move the program expenses. So I wanted to share that. So that's the first one, and those are for, again, $545,000 of ongoing dollars. The second amendment appropriates $604,000. Yes, no, sorry, $604,000 in anticipated beginning working capital in FY26. This amendment rolls over $500,000 of the remaining FY26 contingency earmark for public campaign finance to use as one-time only in FY26. And it rolls over $104,000 from refunds issued, $104,000 from refunds issued on rent assistance paid with ARP revenue in past budget years. So this was dollars that we previously spent, but we got some refund for those dollars. This ARP revenue can be used in FY25, which is going to free up $104,000, I'm sorry, $104,000 in FY25 general fund that can now be used as one-time only in FY26. And so that total amount of one-time only dollars is $604,000 total. I do want to flag, there will be another one-time only revenue amendment that is going to be coming soon. It will be, the reason I'm not bringing it forward today is it actually is dependent on board action that this board would take on May 29th in terms of a budget modification. And so we don't want to presume any kind of board action that may or may not happen on the 29th. But that amendment would be forthcoming pending that board action. And that would be for another $500,000 of one-time only dollars. All right. Okay. And
And you'll send that around?
yeah, and I'll ask Jeff to send those. Can you send a PDF of those different amendments around to the board? Thank you. Okay. Thank you all very much for a really good discussion. And we just started our work in delving into the health department budget, so we will continue that tomorrow. That concludes today's budget work session. Our next meeting is budget work session number 8, scheduled tomorrow, Wednesday, May 21st at 9 a.m. There being no further business, we are adjourned.